Hi guys, hope you're doing good. I shall now be explaining to you regarding diseases of the thyroid gland and we'll begin with a case-based discussion. Today in my outpatient department, there was a patient who was having a huge vascular thyroid gland even at a distance of 6 feet or maybe even 10 feet. When this patient was walking into my chamber, I could see that this guy is having a thyromegaly. So by looking at this guy, I straight away told this guy, sorry, I cannot help you. I would like to refer you to the surgery department. And this person, well, he does not have an option since I've refused to see him. So he again went to the counter, got a slip made for visiting the surgeon, and now he is sitting in front of the surgeon. The surgeon is gonna be very pleased, very happy looking at this patient because you see, bigger is the size of the gland, bigger will be the smile of the surgeon because you see, surgeons love to cut. So bigger the gland, the happier they are. The surgeon has decided to take up this case and he has told the intern to get a total workup of this patient, a pre-anesthetic checkup and a fitness certificate has been obtained. During surgery, however, disaster can strike because you see when the surgeon will have to operate on this patient, he will have to dissect this enlarged gland from the adjoining tissues. So the pressure by the hands of the surgeon or the manipulation by the hands of the surgeon of the large vascular thyroid gland will contribute to release of T4 from the gland. You see the gland is big, it is filled with thyroid hormone. The manipulation of the gland will contribute to surge of T4. You see, if you have listened to the pheochromocytoma discussion, I've highlighted that when you manipulate a pheochromocytoma, there is sudden surge or a release of catecholamines in the circulation. In a similar sense here, when you are gonna manipulate a large thyroid gland, there would be release of T4 in the circulation in very large amounts, which in very few seconds will be converted into T3. And you know that T3 is the active form of the gland. This is going to cause an extensive sympathomimetic stimulation, and the anesthesiologist will notice that the heart rate of this patient is steadily climbing up. You see, if you and me are working out in a gym and heart rate goes up to 130, 140, it is still understandable. But for a person under anesthesia, heart rate of 140 is a disaster. It can contribute to development of high output congestive cardiac failure, and a lots of time these patients may not make it out of the operation theater. We might even have a death on the table. You see, the moment the heart failure will occur, what's going to happen to the patient is that the BP of the patient will crash and the buzzer might start buzzing. At the same time, there would be crepitations in the chest of this guy. These would be fine crepitations of pulmonary edema, and the pulse oximeter will show SpO2 to fall. During surgery, if you have a crashing of BP, crepitations, a falling SpO2, it is almost close to impossible to save this person. If the anesthesiologist will touch this patient now, the patient will be burning hot. Why? Because you know the thyroid hormones also contribute to caloriogenesis. So therefore, the increased heat production in the muscles will contribute to hyperthermia, and that would be like adding fuel to the fire. Why I am saying adding fuel to the fire is like because hyperthermia will contribute to increase in heart rate even further, and there's limited coronary supply. After all, you know, human beings have limited coronary supply. You just can't keep on increasing the heart rate to an undetermined level. So in this person, there is a possibility that he may never make out alive from the operation theater. I have started my discussion of the thyroid gland by actually discussing a very atypical topic. Well, by this point of time, I think you have guessed out the diagnosis of this guy. I am describing regarding thyroid storm. Thyroid storm can occur intraoperatively. However, do not be under impression that it occurs only intraoperatively. It can occur preoperatively also. Well, how can thyroid storm occur preoperatively if a known person of thyroid disease ends up with, let me say, a MI or maybe a stroke or pneumonia or UTI, any intercurrent illness? You see, most endocrine emergencies are triggered by intercurrent illness. Like in diabetic ketoacidosis, I was saying that pneumonia or UTI can trigger DKA. Similarly, today I'm saying that it could be MI, it could be stroke, or the standard illnesses like pneumonia that can trigger a preoperative thyroid storm also. Lots of time it might occur intraoperatively where it might contribute to heart failure and even arrhythmias in a person, contributing to pulmonary edema. At this point of time, I also want to highlight the fact that traditionally the surgeon will talk about giving fluids to a person during thyroid storm. I agree to that. Yes, there is dehydration occurring during a thyroid storm, so you need to give fluids, but The but is, if there's gonna be heart failure, then you have to switch off the IV fluids. So don't be under impression that IV fluids are always to be given in thyroid storm. It depends on the perspective. If it's gonna be a preoperative scenario where there's a dehydration occurring in the patient because there's an increase in pathomimetic drive, yes, you might require IV fluids. But if it's gonna be intraoperative and a scenario is that of heart failure, then you need to switch off the fluids. Another scenario where you can be having thyroid storm is when you are giving radioactive iodine for ablation purposes in a unprepared patient of thyroid storm. The meaning of the word unprepared I'll explain in a while, but I want you to understand that in Graves' disease patient, though we use thyroid ablation using radioactive iodine, if you are not gonna follow the steps of the protocol properly, there's a possibility that thyroid ablation or radioactive iodine itself can trigger a thyroid storm. So it could be preoperative, it could be intraoperative, it could be during radioactive iodine being used during ablation that thyroid storm can be triggered in a person. Let's now look at what is the treatment to be done in this guy. As I highlighted, if it occurs and contributes to heart failure, if there's no heart failure, obviously give IV fluids. But if it contributes to heart failure, then you need to switch off the IV fluids of this person, or if blood transfusion is being given, like lots of time during thyroid surgery, if there's blood loss, then a blood transfusion might be given to the patient. You might have to stop it. I would like to highlight this for record's sake. This is indicated. I mean, when would you stop IV fluids? If you document heart failure, if you document arrhythmias during thyroid storm, then don't give fluids. The drug of choice for management of this condition is propylthiouracil, though in pharmacology they might say propranolol first. They are saying that because they want to teach you regarding cutting of the beta-1 stimulation and controlling the heart rate. Beta-2 is present in muscles, that is where the heat is produced. So yes, propranolol is also used in this condition, but the main drug that would be used would be propylthiouracil. Well, what is the advantage of propylthiouracil? It's simply gonna cause inhibition of conversion of T4 into T3 if you inhibit this peripheral conversion, because as I told you, T3 is the active form of the gland, so therefore the severity of the disease will definitely reduce. Propylthiouracil is not available in intravenous format, so this has to be given via nasogastric tube. In some cases, we might even be using a rectal route to deliver the drug to the patient. I repeat the statement, since IV preparation is not available both in India and in America, it is either a NG tube or a rectal route which is to be used for delivery of the drug. If propylthiouracil is not available, in those circumstances, we can even be using alternative drugs for management of this condition, that is like methimazole. So I would like to highlight the fact that if in a multiple choice question, propranolol is also given, methimazole is also given, and propylthiouracil is also given, then propylthiouracil is to be answered as the drug of choice for management of a thyroid storm. You see, we'll talk about Graves' disease treatment subsequently, where methimazole or carbimazole is the one that is preferred, but here it is first propylthiouracil. Along with this, another drug which will always be useful will be propranolol YA, because as I highlighted, this is going to cut off the beta-1 stimulation. Beta-1 will be contributing to increase in heart rate, and beta-2 is in the muscles, that is contributing to the calorigenesis component. So if I cut off beta-1 and beta-2, it will definitely do a lot of good for this person. I also want to tell you that if the person goes into heart failure, then we do not use propranolol in established heart failure. In those circumstances, we might be forced, because BP is falling now. If BP is falling and you give propranolol, because it's also a relatively long-acting drug, the BP might crash to unrecordable values. So we will be more comfortable giving esmolol to this person to control the spiking heart rate, because heart rate of 130, 140, 150 will definitely increase the oxygen consumption of the heart. So I want to put on the brakes and control the oxygen consumption and prevent the worsening of heart failure in this person. In all endocrine emergencies, we will always read about use of hydrocortisone. One reason you can understand is hydrocortisone will help in spiking the values of cortisol. Cortisol is the stress hormone of the human body. So if you're going to provide the stress hormone exogenously, it will help the body cope with the stress better. Remember the fact that hydrocortisone also can do this activity. It can also contribute to inhibition of conversion of T4 into T3. But the main reason why we are giving hydrocortisone is not to inhibit the conversion of T4 into T3. The primary action is that it will help in augmenting, or it would help in rather enhancing the cortisol levels in the body, because endocrine emergencies, you will always read about usage of hydrocortisone. Along with this, two other drugs which are also given in the textbook. I'm just saying for reference that you don't need to note down. That is just for completion's sake. So even if you do not note down the last two drugs that I'm saying, it will not make a difference because the primary treatment is what I've explained to you. You see, I want you to understand that cholestyramine is also mentioned in the textbook. Why? Because it can help in sequestration of thyroid hormones. Now, the problem is the patient is very sick. So I'm not saying that these drugs are not useful. Obviously, they are used, but the efficacy or the percentage contribution of this drug in saving the life of this guy will be very less. I mean, they are going to be subsequent steps, not the initial steps for this person. By sequestration of thyroid hormones, you are basically trying to do a damage control. So these are not obviously the initial approach. Similarly, even we can be using SSKI, that is saturated solution of potassium iodide. Well, saturated solution of potassium iodide or Lugol's iodine, as they use for the older version, can also be used in a person because it will demonstrate what is called as Wolff-Chaikoff effect. In fact, when I say about the Wolff-Chaikoff effect, I want you to tell, or I want you to understand that Wolff-Chaikoff effect basically implies that when you give mega dosages of saturated solution of potassium iodine, I mean, you're giving substantial amount, it will downgrade the iodine trapping in the body. And if you downgrade the iodine trapping, then the synthesis of hormones in the gland will also be reduced. You are basically trying to reduce the synthesis of thyroid hormones in the gland because they are the ones which are coming into the picture. Please appreciate the milk is already spilt. You see, you're trying to just clean up the mess. But at the same time, what you're also trying to do is at least prevent further synthesis of thyroid hormone. So the last two steps that I mentioned, they would obviously take some time to add. The main approach is get the patient off IV fluids, use ice packs in the person because he's going to be burning hot. Hyperthermia is defined as body temperature more than 41 degrees Celsius. Similarly, supplemental oxygen will be required in the body. If there is severe metabolic acidosis, then soda bicarbonate will be required in the patient. That depends on the value of the fall of pH of the patient. And the primary thing is propylthiouracil. If not given in options, then it is methimazole. Along with that is propranolol, and along with that is hydrocortisone. In fact, hydrocortisone, as I highlighted, will be one of the important life-saving drugs in this person because cortisol is the stress hormone in the body. Well, after listening to this discussion, you will be under impression as if thyroid storm is very common. No, we don't allow thyroid storm to actually occur. How can I prevent thyroid storm from occurring? You see, when this patient with a large toxic multinodular goiter came to me, I straight away told this guy, sir, I cannot help you. Your gland is very big in size and I will not be able to manage you medically. I did not even carefully look at the reports of this guy and I just brushed him off and I referred him to the surgeon. This was gross negligence on my part. I should not have done this. When I get a person with a large vascular thyroid gland, before I send him to the surgeon, it is my responsibility that I need to tell this guy that, sir, if you get surgery done, you could even die. Well, I'm not trying to dissuade the patient from surgery. I'll tell this guy, sir, first I would like to shrink the size of your gland. In all patients who are scheduled for, let me say, a total thyroidectomy in Graves' disease or a near total thyroidectomy for Graves' disease, before you plan surgical intervention in any patient who is having the requirement of it, it could be Graves, it could be toxic multinodular goiter, then you need to give to the patient SSKI, that is saturated solution of potassium iodide or Lugol's iodine to the patient. I was talking about the same drug, even in the treatment part, but what I'm trying to say is prevention is better than cure. Like I was saying, the milk is spilled. You hold the glass properly so that the milk is not spilled. That is what I'm trying to do here. If I will give saturated solution of potassium iodide to the patient for at least 10 days pre-operatively, what's going to happen? It's going to shrink the size of the gland. So you can definitely see and relate to the fact that the gland size is regressed. The surge of T4 and T3 in the blood intraoperatively will be lesser. Apart from this, another action of saturated solution of potassium iodine or Lugol's iodine, the older version, is that it decreases iodine trapping. Another action of this drug is that it will decrease the process of iodine trapping and therefore you will be able to decrease the synthesis of hormones. You see, on a comparative basis, if in a multiple choice question, if I am asked saturated solution of potassium iodide / Lugol's iodine is recommended in thyroid storm when, you see it is used both pre-operatively as well as it is used intraoperatively, but the primary usage is pre-operative. The primary usage is pre-operative. You need to prevent the milk from spilling rather than, cleaning the mess after the milk has spilled over from a glass. So I would like to downgrade the iodine trapping, shrink the size of the gland, and reduce this complication from occurring in a patient. Otherwise, obviously, my patient can die. Now let's work up a quick summary of whatever I have just told you at the moment so that you can understand what thyroid storm is all about. You should be knowing how can you prevent thyroid storm. You should be familiar about what causes death in this condition, what are going to be the clinical manifestations of this disease, and what's going to be the drug of choice for this condition. For prevention purposes, we can use SSKI, saturated solution of potassium iodide. I repeat that again, it can be used both intra-op, it can be used if it develops, and pre-operatively, but pre-operative is the primary answer. The mechanism of action of this can be extensively asked, or is, I would say, a hot favorite of our examiners. I mean, whenever you see thyroid topic, the examiner would always love to ask you about two. One is Jod-Basedow and second is Wolff-Chaikoff effect. Jod-Basedow I'll explain to you in few minutes from now, but Wolff-Chaikoff effect basically means downgrade of the trapping mechanism. The primary reason why this patient can die is due to congestive cardiac failure. If congestive cardiac failure is not given in options, then your answer would be given as arrhythmias. It would be tachyarrhythmias, obviously, that can contribute to low cardiac output in a person. From the clinical perspective, you need to document that this guy is having thyrotoxicosis. That is, free T4 and T3 in the body is elevated. Thyrotoxicosis should be definitely lab proven. I have already scanned the report of this guy's pre-operatively, so I know it's a case of thyrotoxicosis, maybe a Graves' disease patient, a toxic or solitary adenoma, or a multinodular goiter. But I know the fact that from the laboratory reports that this person is having features of hyperthyroidism and thyrotoxicosis. Along with this, now what's going to happen in the patient would be development of fever. That's again, as I explained, you see the beta 2 stimulation in the muscles is going to contribute to the calorigenesis component being increased, and therefore hyperthermia would occur in the person. Then you could be having central nervous system features, you could be having cardiovascular manifestations, you could be having GI manifestations, you could be having liver manifestations of the patient. From the CNS perspective, I want you to remember that in this patient, there can even be delirium, there could be seizures, and even a coma. It could be happening intraoperatively or it could be happening preoperatively. That we really cannot predict. I mean, endocrine emergencies can strike at any point of time. Preoperatively usually can be seen triggered by intercurrent illness or radioactive iodine, as I've highlighted, being used in an inadequately prepared patient of Graves' disease. So CNS manifestations can occur. From the CVS perspective, as I highlighted, the rhythm of the heart will be compromised, the cardiac output will be compromised, low cardiac output, crashing of BP during surgery is anywhere disaster. The GI complications that can occur in the form of nausea, vomiting in a person, and diarrhea, and the liver manifestations can be even in the form of jaundice. So do not be surprised if in a multiple choice question, in a documented case of thyrotoxicosis, he starts describing all these manifestations. Why I have described them separately before you is because I want to highlight that if it's going to be intraoperatively, then straight away the blood pressure will crash. I mean, whenever you read about a thyrotoxicosis patient being operated upon and there's a hemodynamic collapse of the patient, either it is bleeding, thyroid surgery contributes to a lot of bleeding. So the surgeon has nicked an important blood vessel, the guy is bleeding, that is why his BP is sinking. But here the surgeon has not caused any trauma to any blood vessels. Still the BP is crashing because the heart is failing due to thyroid hormones. Whereas if it occurs pre-operatively or let me say after radioactive iodine uptake, then subsequently these could be the features given in the question. So it can be both intra and pre-op is what I'm trying to explain to you. You just need to get the features right. From the exam perspective, they can incorporate a name of a scale, which I'll just show before you. Though this scale has never been asked in the exam, but I just thought that I should incorporate this in the discussion so that you are more comfortable with the topic. You see, we have a scoring pattern available as of now. The scoring pattern which can help you grade as well as analyze and therefore intervene in a case of thyroid storm relatively faster is called as Birch-Wadsofsky scale. Now, when you read the features of it, the features are same as what I've highlighted. You can see it's written thermoregulatory dysfunction in a patient. The grading is with respect to the increase of body temperature. There is cardiovascular implications in a patient, tachycardia, atrial fibrillation developing. Then can be GI manifestations like nausea, vomiting, diarrhea. Then CNS manifestations like delirium, psychosis, and then, as I highlighted, even jaundice can occur. So you need to remember, for diagnosis of thyroid storm, in a documented case of thyrotoxicosis, out of these manifestations that I've written before you, at least three should be present, like CVS, CNS, GI, or hepatobiliary. I mean, I can just put a slash. So if you get these three manifestations with thyrotoxicosis patient developing sudden onset high grade fever, intraoperative diagnosis will never be a problem for you. Because crashing of blood pressure during surgery, as I said, either it's due to bleeding or it is due to a heart failure. It is mainly the pre-operative scenario which can definitely cause a little bit of error of judgment on your part. That is why I'm highlighting the fact that if you have a laboratory proven thyrotoxicosis, the patient starts developing high grade fever and then starts having these CNS, CVS, and GI manifestations, these three that I put a tick mark, it means that you are clinically on spot for diagnosis of this condition. And we have a scaling pattern also, which is mentioned here. I mean, even if you do not remember the name, I want you to remember that if the total score is more than 45, it is suggestive of thyroid storm. If the score is lesser, then it is impending. Even if you do not remember the name of the scale, it is okay by me, but higher is the scale. Like in this case, you can see that if the score is more than 45, higher chances. If it's less than 25, the chances are relatively lesser. So we can quantify the severity of manifestations in this person, and therefore the chances of you saving the life of this person will also be increased. I shall now be comparing this topic of thyroid storm with Jod-Basedow effect. You see, during the discussion of thyroid storm, I had explained to you that we use saturated solution of potassium iodide preoperatively to prevent the development of this manifestation because it decreases the iodine trapping. Now compare this with what I say next. This is an Indian patient. He is taking excess amount of iodized salt on a daily basis. You see, India has now come out of iodine deficiency state. We are familiar with the fact that in our country earlier iodine deficiency was very common. That is why the government was promoting intake of iodized salt. But now, as such, we urban Indians do not have iodine deficiency. But still the government is persisting with the usage of iodized salt. So this is going to act like a double-edged sword now. What I mean by double-edged sword is that in a person who's not iodine deficient, person like you and me who's eating seafood regularly, for example, in people like you and me, we are still taking iodized salt on a long-term basis in excess of what is required. So this can definitely upgrade the process of iodine trapping. If iodine trapping will increase, then there will be more synthesis of T4, and therefore this person can start developing features of thyrotoxicosis. This manifestation, where a person is not having any Graves' disease, there is no autoimmunity present, but still there is excess synthesis of thyroid hormone in the body of this person. Why? Because he is taking more of iodized salt. This manifestation is technically called as Jod-Basedow effect. In the exam, most of the time, the examiners love to ask regarding Wolff-Chaikoff and Jod-Basedow. Both of them are diametrically opposite of each other. When I give this description, the query of most doctors is that, sir, what will decide whether it's going to be Wolff-Chaikoff, whether it's going to be Jod-Basedow, because in both you were talking about iodine being taken. So let us just go into a quick summary here. Please remember, saturated solution of potassium iodide. Here I am using large dosages of iodine. But these large dosages of iodine I am giving only for, let me say, 10 days only. And therefore, I will be able to contribute to, because large dosages of iodine has been given to the patient, it will downgrade the process of iodine trapping, and that is why the synthesis of T4 hormone will reduce. This is Wolff-Chaikoff. On the other hand, when I'm talking about iodized salt, then I'm giving very minimal, or I'm writing minute dosages of iodine, but they are being taken for large number of years, let me say 20-25 years. Then there will be upgrade of iodine trapping in the person, which is going to contribute to increased synthesis of T4. I want you to remember the fact that it is not that it is discretionary, it is rather having a valid reason. When you give mega dosages, the inhibitory mechanism will work. When you give minute dosages for long duration, the stimulatory mechanism will work. The first one that I've written before you is called as Wolff-Chaikoff. And the second one is already on the board, that is Jod-Basedow effect. But just to make you remember this, I'm making you practice writing this down once again. Wolff-Chaikoff and Jod-Basedow are quite frequently asked in the exam, so it's a good idea to actually write down the information that I put up in the green box. Now let us compare this with an alternative discussion. Instead of giving you the name, I'll first give a short description of a Western American patient. You see, America, Canada, China, these are primarily beef eating countries. This particular person is eating beef, but the bad news is that this is poor quality beef where the thyroid gland of the animal was also pounded into beef. The person is obviously not aware of it. He's gonna eat this poor quality beef. He's not aware that it is containing the pounded thyroid gland of the animal as well. So since he's having exogenous intake of thyroid hormone, therefore there's a distinct possibility that later on this person might start developing standard features of hyperthyroidism, thyrotoxicosis like palpitations. That's because sympathomimetic stimulation will drive up the heart rate of the person, or because of the calorigenesis component being increased in the person, this person will develop heat intolerance. Features of thyrotoxicosis are developing in a person, but not primarily because of intake of salt. It is due to another cause different from salt, that is poor quality beef. In my neurology discussion, I have told you poor quality beef can contribute to development of VCJD, that is variant Creutzfeldt-Jakob disease. But today I'm teaching you about this very peculiar presentation that is called as thyrotoxicosis factitia. The learning for you guys is that if salt is the villain, then you use the term jod-besto. If salt is not the cause, then you will use the term thyrotoxicosis factitia. Let's take up another example primarily from India that will make you more comfortable with this term factitia. You see, obesity is increasing in our country on a regular basis due to the food habits that we have. It involves a lot of frying, lots of carbohydrates in our food diet. So therefore, because obesity is increasing in our country, you will notice a lot of advertisements over the internet, over social media of various kinds of Ayurveda medicines. These Ayurvedic medicines will claim, or these advertisements will claim, that these are rare herbs from the deep jungles of the Himalayas. They'll portray it as some magic remedy for weight loss. But the patient is obviously not aware of the fact that this so-called Ayurvedic medicine without any side effect is actually having levothyroxine extract. The patient is not even aware of the fact that he's eating levothyroxine daily. It will increase the basal metabolic rate of this person, and this will contribute to weight loss, and this person will be very happy. He will even call up his relatives and say, you should take this Ayurvedic medicine, it's very effective, it helped me lose weight. I tried gymming, I tried exercise, nothing was working. But the moment I started taking this so-called Ayurveda medicine, I ordered it from the internet, it is causing a weight loss. He's not realizing that by the second or the third month, because he's taking thyroid hormone from outside, that's not a joke. The thyroid hormone will keep on increasing the oxygen consumption of the heart. The heart rate will increase, the oxygen consumption of the heart will increase, and there's a distinct possibility that this person can even develop chest pain. He will start developing angina. You might think that he's having blockages in his coronary artery. You started doing stress echocardiography, coronary angiography, reports were coming normal because there's no blockage in the artery. It is this Ayurvedic medicine, the supplement, which is causing it. A lot of patients who are having intake of Ayurvedic medicines, because Ayurvedic medicines, they don't really mention the exact composition. They could be having steroids, so that can contribute to Cushing syndrome. Today I'm saying Ayurvedic medicine could be having levothyroxine extract. This is misselling. This is misselling on the part of the Ayurvedic company, but the end result is a person can land up even with heart failure. This description that I've highlighted before you is because the person is having a exogenous intake of thyroid hormone. I want you to remember that whenever you read this term factitia always implies exogenous intake. I have today given you an American example of factitia, that is cattle or beef being consumed of poor quality, the meat being consumed of poor quality, or this Ayurvedic medicines being consumed for treatment of obesity. Instead of exercising and restricting his carbohydrates, this chap is trying to use medicines to lose weight, which is not a very proper method. The end result is he ends up with hyperthyroidism manifestations. So the term used is factitia. The basic carry home message for you guys is, if salt is the troublemaker, then we will use the word jod-besto. If it is any exogenous source, we will use the word factitia. And when you are using SSKI, saturated solution of potassium iodide or Lugol's iodine, then it's going to be Wolff-Chaikoff effect, because you're giving mega dosages of iodine in short duration of time. So you're going to inhibit or decrease the iodine trapping in a person. Now you will notice that I have been using these terminologies very regularly. Like sometimes I'm using the word hyperthyroidism, and another time you don't need to note this down, just follow my words. I mean, just for your understanding purposes, you see, the baseline words I have been using are hyperthyroidism, and sometimes I'm using the word thyrotoxicosis, and they are used interchangeably also. So do they mean the same? Well, hyperthyroidism, as is meaning from the word English, implies it is gonna be increased in the function of the gland. This implies that the person could be having, for example, Graves' disease, where the function of the gland is increased. But thyrotoxicosis is only a manifestation. It means that there is excess T4 in the body. Now, the reason for this excess T4 can even be jod-based ono. I just explained to you in jod-based effect also, because there's upgrade of iodine trapping, there's more T4 there. The gland is not working more there. Similarly, if a person is taking levothyroxine extract in Ayurvedic medicine, still T4 will be more because he's taking levothyroxine extract. The function of the gland will be normal. So please appreciate the fact that the disease is hyperthyroidism. Thyrotoxicosis simply means hormonal profile of a person, and thyrotoxicosis can occur without hyperthyroidism also. Looks surprising? Let me write it down before you. You see, thyrotoxicosis simply means that there is more thyroid hormones in the body. It is not a guarantee that all patients with thyrotoxicosis will be having hyperthyroidism. In the exam, they can write thyrotoxicosis without, the word is without hyperthyroidism. You see, the concept here is, or what is trying to see in your thought process is that are you aware that these two terms definitely mean different? For example, let us take up a scenario of a person having subacute thyroiditis, where it could be, let me say, virus, or it could be autoantibodies which could be damaging the thyroid gland. Now, if it is thyroiditis, the gland is damaged. So the manifestations of the person would be the gland is damaged. I'm not saying gland is working more. No, let's see what I was saying for hyperthyroidism. Gland should be functioning more. In thyroiditis, what will happen is the gland is destroyed. That is why the levels of hormones in the body will rise. So whenever you read terms like subacute thyroiditis or silent thyroiditis, just focus on the English here. Thyroiditis means the gland is damaged, and therefore there could be features of thyrotoxicosis. That is, hormones will be more, but the gland is not working more. So I'm writing the word without. I've already explained this to you, but I need to put this on record. Thyrotoxicosis factitia occurs with respect to iodized salt. I've already put this on record that if a person is taking exogenous intake of levothyroxine, then we call it thyrotoxicosis factitia. Here also the gland is not working over time. There are three important causes that I want you to remember for thyrotoxicosis without hyperthyroidism. The English words which are to be remembered are thyroiditis 2 times and factitia. Just to see whether you got me or not, I can write in a fourth cause. Suppose you are giving radiation to destroy the thyroid gland, then radiation can also contribute. I mean, you may not be actually giving radiation per se directly from exogenous source to destroy the thyroid gland. It could be radiation to the neck for a person who's having maybe secondaries in the lymph nodes. Or it could be a patient of Hodgkin's lymphoma with enlarged cervical lymph nodes. So when you give radiation, there's a possibility the thyroid gland can also be destroyed. Or another possibility can be due to drugs. You see, amiodarone in large amounts can physically cause damage to the gland. That will cause release of T4 in the circulation. Or suppose there is infarction in a large thyroid tumor. You see, thyroid tumor will increase very fast in size. It will outgrow its blood supply. If a tumor will outgrow its blood supply, infarction of a large tumor can again contribute to destruction of the gland, and then the word is destruction. So therefore T4 will obviously increase. The gland is not working overtime, no? So I'm writing thyrotoxicosis without hyperthyroidism. This is just a terminology that can be used by the examiner to trouble you. So I just want you to be familiar with the fact that hyperthyroidism means gland is working overtime. Thyrotoxicosis means only hormonal profile is more, and both are not interchangeable. You can have situations where the gland is destroyed. The word is destroyed, not working over time, like in thyroiditis, which will contribute to increase in the levels of T4 and T3 in the circulation. But at the same time, the gland was not working over time. It was rather getting affected. We now come to the main agenda. What is going to be causes of hyperthyroidism? So when you read the textbook, no, you will not see the word causes of thyrotoxicosis, because thyrotoxicosis can be due to exogenous intake also. He will always use the term hyperthyroidism. Now here, He can talk about primary and secondary. Whenever you read the term primary hyperthyroidism, it implies that the gland is working overtime. Secondary means pituitary is working overtime. The antibody which is present here is called as LATS, that is long acting thyroid stimulating antibody. This antibody will behave like TSH. It will behave like TSH, it will activate the gland, and the gland will work all the time, then T4, T3 values will increase. The alternative name for LATS, because LATS is what was mentioned in Bailey and Love, long acting thyroid stimulating antibody. In medicine books, it is written as thyroid stimulating immunoglobulin. Lots of time there's a possibility that in the exam, because he knows that you will be able to correct the question on the word LATS and TSI, so he might write an alternative term TBII. TBII is the technical name for evaluating TSI. The word is thyrotropin binding inhibitory immunoglobulin. You see, you can very well see the way I'm writing the information before you, there's a distinct possibility that you might be so focused on the word inhibitory immunoglobulin that you may not realize that he's talking about Graves' disease, because Graves' disease per se is gonna be stimulation of the gland by an autoantibody. The word is thyrotropin binding inhibitory immunoglobulin assay, or TBII assay, as is mentioned in multiple choice questions. Whenever this is given to be positive, it means that he's talking about this thyroid stimulating immunoglobulin. He will write TBII, but technical meaning of that is he's talking about TSI. The TSI will mimic the chemical structure of TSH, so the gland will be stimulated 24/7. In these patients, the production of T4 will rise, the production of T3 will rise, and by feedback mechanism, TSH will become almost undetectable. This is itself a question that is to be remembered, that in primary hyperthyroidism, the values of TSH almost become undetectable, substantially reduced. This presentation that I mentioned before you is technically called as Graves' disease. Approximately 80% cases of hyperthyroidism overall will be coming to you because they have developed Graves' disease. But because, again, this is easy, he might write in the MCQ secondary hyperthyroidism. When you read this term, it means he's talking about a pituitary adenoma. It could be a micro, it could be a macro adenoma. Now see what this pituitary adenoma will do. It will cause an excess synthesis of TSH. More TSH will stimulate the gland to cause more production of T4, more production of T3. You can see in the lab report that TSH, why is it called as best thyroid function test? Because it can not only tell you that there's a problem with the gland, it can also differentiate whether it is a primary cause or whether it is going to be a secondary cause. In lot of questions, whenever you read the report, you should immediately be able to analyze in the report at a subconscious level in your brain, because the answer will depend on that. If it's a pituitary adenoma, you need to resect it. You need to go for transsphenoidal surgery. Whereas if it is Graves' disease, then you shall be using antithyroid drugs or radioiodine ablation for the patient, or if required, even a total thyroidectomy. The answer will change based on the report. So analysis of the report is primary importance in this topic. Once you're done with primary and secondary, we move on to a third important cause that I've highlighted, which could be from surgery, like toxic multinodular goiter. Now, would you classify toxic multinodular goiter as primary or secondary? So as I explained to you, secondary always means pituitary. Toxic multinodular goiter is gonna be a primary cause, or it could be a toxic adenoma. I mean, he can use any of these terminologies in the question and ask you which of the following is a secondary cause. The answer would be a pituitary adenoma causing overproduction of thyroid stimulating hormone. A rare cause here can be activating mutation of TSH receptor. You see, this is different from Graves' disease. In Graves' disease, what was happening was the antibody was behaving like TSH. The antibody was behaving like TSH, but here I'm not talking about any antibody. I'm just saying that the receptor is working overtime. Like if you listen to the discussion of mine in adrenal gland, Cons syndrome and Liddle syndrome. Cons is overproduction of hormone. And when it comes to Liddle is the channel working more. Similarly here, it is not the hormone. I have written activating mutation of TSH receptor. So that means that in the body, it's the receptor, gain of function of the receptor due to genetic reasons. So deliberately, I mean, he can incorporate these terms. The bottom line is that in this situation, there would be overproduction of the thyroid hormones in the body of this person. At this junction, I want to tell you that if your evaluation shows none of these disease processes present in the patient, then You have to think in terms of possibility of jod besto. Dietary intake has to be evaluated here. But if jod besto is also not present, there is no drug intake which is responsible for it, then assuming the fact that none of these causes have been demonstrated, then you need to think in terms of jod besto. Jod besto is due to either iodized salt or could be due to drugs like amiodarone. But if jod besto is not the cause, then it could be thyrotoxicosis factitia, that is exogenous intake with respect to so-called Ayurvedic medicines that I explained. Assuming the fact that these rare causes have also been ruled out, then in a female patient especially, you need to rule out a possibility of a ovarian tumor which could be causing excess synthesis of thyroid hormones, that is stroma ovari. As I've explained to you, stroma ovari will also be classified as a primary cause. Primary because here it is an ovarian tumor that is causing, but after all the problem is not in the pituitary, so this would also be classified as a primary cause. Assuming the fact that none of these causes are found, then I want you to remember that TSH, thyroid stimulating hormone, and HCG, human chorionic gonadotropin, they have almost a similar kind of structure. So if in any condition HCG will rise, it will behave as if, because the chemical structure is partially the same, so it will behave as if the TSH is more, and therefore the end result will be more stimulation of the gland. Condition in which you are having excess HCG production would be gestational trophoblastic neoplasia. In your gynecology class, you were taught regarding hydatidiform mole, which causes excess production of beta HCG, and the end result is it will behave like TSH. So therefore, there's a possibility that it could be a gynecological cause like GTN also given. These are the 7 important causes that I want you to remember for hyperthyroidism, where he can mix and match the information saying all our causes are primary, except just remember if the pituitary is the troublemaker, it's going to be called as secondary. Another aspect that I've highlighted before you is thyrotoxicosis without hyperthyroidism. The concept behind this is simply the fact that you may have a excess of hormone in the body even without the thyroid gland not working overtime. As I explained, thyroiditis implies destruction of the gland, or it could be radiation induced damage, it could be drug induced damage, it could be infarction of a large tumor. So once you get these concepts right, you will be in a better position to understand the clinical manifestations of the patient. Next, I would like to tell you regarding the interpretation of thyroid scan, which is very simple and straightforward. There are 3 terms that I want you to be familiar with, that is a warm nodule versus a hot nodule versus a cold nodule. Now, if I ask you what do you mean by the word warm nodule, then warm nodule implies normal uptake, whereas when we talk about hot nodule, it obviously means increased uptake. But when it comes to a cold nodule, then it is suggestive of a malignancy. Cold nodule is suggestive of possibility of a cancer. For the hot nodule, I'll show you a couple of images here so that the interpretation part in MCQs becomes relatively simpler. The iodine that is used for thyroid scan would be iodine 123. You see, for ablation purposes, we use iodine 131 with a half-life of 8 days. It produces beta rays and it destroys the thyroid gland. But this time for diagnostic purposes, I'm not going to use iodine 131. I'm going to use iodine 123, or I can be using iodine 132. You are familiar with the questions on the half-life of these isotopes, so I hope you remember this from even your radiology and radiotherapy discussions, that 13.2 hours for iodine 123 and for iodine 132 it is only 2.3 hours. You see, I want to minimize the radioactivity exposure of a person for diagnostic purposes. For therapeutic purposes, I will obviously use iodine 131, but this is primarily a diagnostic approach. As I highlighted to you, cold nodule will show a decreased uptake that is suggestive of possibility of malignancy, and most of the time radiation-induced thyroid cancer is papillary cancer of thyroid, where you read about orphan ani nucleus from pathology domain. On the other hand, when we talk about Graves' disease, it will always be having an increase of uptake of the gland, but this would be a diffuse uptake that would be increased. Compare this with toxic multinodular goiter, where you will be having a focal uptake that is increased. So it is easy to differentiate between the two images in a sense that if it is uniformly black, diffuse uptake; if it is patches of some area being black, then it is focal uptake. And obviously the cold nodule will show up less uptake than normal, so the area would look almost white or there is hardly any uptake present. Compare this with the image at the bottom where there is a diffuse decrease in the uptake. In this image, you can notice that the gland is very much present, but as such the normal shape of the gland cannot be delineated. The diffuse uptake is less because we are talking about autoimmune destruction of the thyroid gland, that is Hashimoto's thyroiditis, where the radioactive iodine uptake is less than 5%. The only possibility where errors can occur in interpretation can be in the last two, which are now on the focus in the slide. The confusion can be between a hot nodule and an autonomous nodule. Now, how to differentiate will be the background image. If you see a hot nodule, that is a dark black area, but you can definitely visualize the gland, at least the gland morphology, the shape of the gland can be visualized, then you are gonna call it a hot nodule. On the other hand, when I say autonomous nodule, the highlight is that there is suppression of the remaining of the gland. No gland is visualized. So let's just recap these images once again. The points to be taken into notice are, if you have a decrease uptake, uniformly black spots increase, that is Graves. If it's diffusely decreased uptake, it can be Hashimoto's thyroiditis. If it's gonna be a hot nodule present versus an autonomous nodule, chances of error are minimized by remembering. Then if it is a hot nodule, you can visualize this image, you can visualize the gland also, you can at least make up some morphology that the contrary side of the gland can also be seen. But you look at the corresponding image on the right side of this, there is absolutely no background gland visible, so we're gonna call it an autonomous nodule. Apart from this, toxic multinodular goiter is pretty straightforward to pick up because, as the name suggests, multinodular goiter, so there's some areas where the uptake is definitely increased. When it comes to thyroid scan interpretation, it helps you in multiple choice questions. They may give an image, they may not give an image, but if they give a report, then you should definitely be able to pick it up. Based on this, I shall now be explaining to you regarding how the patient will present to you. Coming to the clinical manifestations of the disease, the features will depend upon the severity of sympathomimetic stimulation because thyroid hormones have a sympathomimetic profile. If the question is simply asking regarding the early manifestation of the patient, then your answer would be given as hyperactivity and irritability. I know that these two words will sound very non-specific, but that is how it is described in the textbook. The early feature of hyperthyroidism would be hyperactivity, irritability. However, subsequently, due to activation of beta 1, beta 2, there would be very specific features in the form of the patient saying that I can feel my heart racing in my chest. Now, since Graves' disease is an autoimmune disorder, approximately 80 to 90% of patients will be having Graves' disease as a presentation, and all autoimmune disorders are more commonly seen in women. So, most of the MCQs will start by describing a young female and then will go on to describe these features. Beta 2 receptors are present in muscles, so therefore the symptom that will develop in the patient will be fine tremors. In fact, a lot of these patients might be having sweaty palms and sweaty feet, and therefore these patients might be embarrassed to shake hands with people. These two manifestations that I have just now written before you, that is palpitations, fine tremors, you read about these even in pheochromocytoma. But there must be something extra present in this patient which will help you differentiate from pheochromocytoma versus hyperthyroidism as a presentation. Well, when I described pheochromocytoma to you, I was just saying the word patient will be having episodic hypertension or paroxysmal hypertension. Why? Because catecholamines have a short duration of action, but in this patient, it will always be a sustained hypertension. Along with this, since basal metabolic rate of the patient would be enhanced, there will be a concomitant weight loss in the patient. Because the calorigenesis component or the heat production in the body will also be increased, so you will have this very characteristic word written in the MCQ or in the textbook, heat intolerance. You don't read these terms like heat intolerance and cold intolerance in any other topic apart from thyroid discussion. So the moment you start reading a question that is having sympathomimetic symptom profile, you have to think in terms of both pheochromocytoma and hyperthyroidism. One of the key words that will help you in differentiating will be this word heat intolerance. Now, because we were talking about a female patient, so menstrual abnormalities can also be given in the question. This lady who's losing weight will be having oligomenorrhea. In contrast, the early menstrual abnormality in hypothyroidism is menorrhagia. It's actually opposite. In hyper, it is oligomenorrhea. In hypothyroidism, it is menorrhagia. And there's a distinct possibility that this lady, she got married, but she's not being able to conceive. Or for that matter of fact, she's already having one child, but she's not able to have a second one. So the question could mention primary or secondary infertility. Now, once you read these symptoms, you obviously know that you are dealing with a case where thyroid hormones or more sympathomimetic drive is increased in the patient, leading you to the diagnosis or helping you in the question will be the following word, which is one of the early clinical signs and a reliable clinical sign. When I say this statement, you will yourself realize that you don't read this statement very often. I mean, normally we check the pulse rate of a patient whenever we want to, but in hyperthyroidism, especially Graves' disease, you will read in the textbooks this classical term written, increase in sleeping pulse rate. Well, why are you checking sleeping pulse rate? You could have checked the awake one also. So the technical issue is that you're trying to differentiate this patient from a patient of type A personality. From psychiatry, you would know that type A personality will be what we casually call as a hyper individual. This type A anxious personality would be also having an increased sympathomimetic drive, so heart rate can be increased when the person is awake. But when a person of type A personality will sleep, then the heart rate will come back to normal. But in hyperthyroidism, whether a person is awake or sleeping, it does not matter now. In a hyperthyroidism patient, thyroid hormones are always gonna be increased in the body. So there's gonna be continuous sympathomimetic stimulation. So whether he's awake, whether he's sleeping, the heart rate will always be increased. So the word written is increase in sleeping pulse rate, or he might just use the word resting tachycardia. I also want to tell you that patients of hyperthyroidism, especially elderly patients, are predisposed to arrhythmias. If the question simply says what is the commonest rhythm, mark my words very carefully. If the question says what is the commonest rhythm seen disorder seen in, or a rhythm seen in a hyperthyroidism patient, your answer would be given as sinus tachycardia, because obviously I've written increase in sleeping pulse rate, so it does not make any sense for me to write regarding sinus tachycardia as a word. But I want you to remember that they can definitely have troubles and they can even develop stroke, because they could be having clot formation in the left atrial appendage. Why? Because the person can develop atrial fibrillation. So please remember the fact that though common is sinus tachycardia, but that will not interfere with the quality of life. In a sense, it will not cause stroke. But atrial fibrillation, as you are aware of from cardiology discussion, is capable of causing clot formation in the left atrial appendage. So these clots can embolize into the brain, and therefore embolic stroke manifestation can occur in a patient. Continuing with the sympathomimetic drive, the examiner will waste next 10 to 15 seconds of your time in the MCQ by describing features of loud S1 or ejection systolic murmur. Why? Because the patient is having a hyperdynamic circulation. In fact, when the heart is beating very fast, there might even be a scratchy sound in the chest. The term that is used to describe this scratchy auscultation finding is called as means Lerman scratch. All these findings that I've written here before you basically highlight the fact that the circulation of a thyrotoxicosis patient or hyperthyroidism patient is a hyperdynamic circulation thanks to the sympathomimetic stimulation that is occurring. As you proceed with the general physical examination, you will also notice that this person will be having myxedema. Please remember the fact that myxedema is not only seen in hypo but is also seen in hyperthyroidism, and mainly it's gonna be in the pretibial area. This pretibial myxedema, which is very characteristic in Graves and is also referred to as a dermopathy manifestation, will appear initially in color orange. So most of the time in fair skinned individuals, and there has been an image based question where on the shin of the person, initially the lesion that was developing was only in the form of a orange discoloration, and then the lesion will also become palpable, that would be papule, and then it will start having an irregular surface. In the advanced stages it might even look like elephantiasis to you, but initially it would be orange discoloration and a disfigurement that would be developing on the shins of the person. From image-based MCQ perspective, lesions that I've explained to you on the shin, from GI perspective, I'll just use a different color coding to make you remember. One of the image-based questions that I've discussed in GI segment is pyoderma gangrenosum. Pyoderma gangrenosum has been discussed with inflammatory bowel disease. It's one of the extra intestinal manifestations that is encountered, and what I want to highlight is that per se for this disorder in pyoderma gangrenosum, the lesion or ulcer will be found on the shin. Then in diabetes mellitus topic, I have talked about a lesion on the skin of the person on the shin again, that is necrobiosis lipidoica diabeticorum. In fact, this lesion will be having a reddish appearance with a central clearing. So you can go through the diabetes section if you have not. And then obviously at the moment I'm talking about hyperthyroidism, pretibial myxedema, also having a lesion on the shin. So these are names that you need to remember. And for ulcer on the shin, another term I can use is martorell ulcer, M-A-R-T-O-R-E-L, T-double-L. Martorell ulcer is something that you will read in surgery that could be seen in patients of hypertension and atherosclerosis. I also want you to remember that this myxedema is actually a lymphedema. Therefore, it's gonna be of the non-pitting variety. Continuing with the sympathomimetic stimulation, you will start getting a very peculiar manifestation of lid lag developing in this person? Well, why am I saying lid lag? Because of the sympathomimetic stimulation, what's going to happen is that there's going to be contraction of the Muller's muscle, or I can use the word retraction of the upper eyelid. Therefore, the person will not be able to follow an object from top to bottom. Like I can move my eyes from top to bottom, left, right, sideways, whichever way, but I can definitely move my eyes from top to bottom. In this case, you will notice that lid lag will definitely be present. That's again because of the contraction of the Muller's muscle. In fact, in the later stages of the illness, because the extraocular muscles here get involved by the myxedema component. You see, what happens is two things. With extraocular muscles, what happens is one, there could be retrobulbar fat deposition. Apart from retrobulbar fat deposition, there could be myxedema related to the muscles. So there's going to be deposition of glycosaminoglycans. You're aware, myxedema, lymphedema implies that here there is increased deposition of glycosaminoglycans and they have a tendency to retain water. So once there is a swelling developing, therefore the extraocular muscles will take up more space. And because the muscles are swollen and they're taking up more space, they will push the eyeball anteriorly. And that is why you would be having proptosis in these patients. It is a distinct possibility that in these patients, initially proptosis may be unilateral. It can be bilateral. It may be asymmetrical proptosis. So don't be under impression that proptosis will always be bilateral and it always takes some time to develop. In fact, proptosis is not the earliest ophthalmic finding that you encounter in these patients. Initially, there are no signs and symptoms in the patient. In fact, if we ask you that what is the earliest manifestation of thyroid ophthalmopathy, then do not answer proptosis. You can see here that initially what is going to happen in the patient would be features like lid retraction or a lid lag, as I said, because of the contraction of the Muller's muscle, because Muller's muscle operates on sympathomimetic drive. So the earliest manifestation is not proptosis, as you can see, and I'm highlighting this again. It is lid lag, which is to be answered first. Then is going to be soft tissue involvement in the form of a periorbital edema. This periorbital edema might even initially respond to diuretics, but subsequently it's not going to respond to diuretics and it's going to remain permanently. And subsequently you will be having pushing of the eyeball anteriorly, that is proptosis. In the later part of the illness, there could even be corneal involvement, because let me put it like this. In fact, I can draw a diagram for it. You see the upper eyelid of yours and mine covers approximately 2 millimeters of the cornea. The upper 2 millimeter of the cornea is not visible in any one of us. In this patient, what is happening is a retraction of the upper eyelid, as I've shown symbolically. So you can not only see the upper 2 millimeter of the cornea, but you can even see the sclera. In fact, in this image that I'm showing you, you will notice the classical stare sign that is described in the textbook, that even the sclera is visible. The white of the eye in the upper part just above the cornea is also visible, which does not happen in any one of us. So therefore, from the MCQ perspective, please remember the fact that it is not proptosis that is the early feature. It is lid lag that will occur in this person. As the disease will progress, you see there is pushing of the eyeball anteriorly, there is retraction of the upper eyelid in the patient. So the manifestations that will occur will be in the form of inadequate blinking. Let me explain this once again. You see, when you and me blink, our upper eyelid washes the whole cornea. If I blink, my upper eyelid will wash all the cornea. But in proptosis, when the eyeball is pushed anteriorly, and even the upper eyelid is not moving normally because of the lid lag component, there is an inadequate blinking. So I have seen a patient of Graves' disease who actually used to sleep with eyes open. We had to actually use patches so that the person could sleep, otherwise there would be corneal damage, there would be even a corneal opacity subsequently, and patient can go blind. Inadequate blinking will contribute to development of exposure keratitis. So no big deal that these patients might lose their vision, or they might initially tell you that I can have a sand-like sensation in my eyes or grain-like sensation in my eyes because of the exposure keratitis component. In the later part of the illness of the disease, it can even so happen that the same patient might even lose vision, not only because of the component of exposure keratitis, but there's another reason which I can explain with help of this diagram. Let us take this to be the representation of the eyeball of the patient and the cornea, and the red represents the extraocular muscles. Once these extraocular muscles are involved, even a symptom will develop in this patient. You would have read in surgery books that the commonest extraocular muscle that is involved in this condition is inferior rectus, and because of this, even the symptom of diplopia can come. Now, this is a bad thing. Why I'm saying this is bad news, why it's a bad thing, is because as the muscles will get progressively involved here, so I'm symbolically showing that glycosaminoglycans is retaining more water. There is also a retrobulbar fat deposition. So all this soft tissue and muscles is taking up more space. Not only will this push the eyeball anteriorly, but it can even put pressure on the optic nerve. You can see that the optic nerve can be affected. So why I was saying the word bad news was that the patient could be developing retrobulbar neuritis. In fact, if this is happening, we might even have to use methylprednisolone for these patients. Retrobulbar neuritis that occurs in these patients can explain the blindness. So there are two reasons why I said there could be blindness occurring in these patients. One is obviously the corneal damage because of inadequate blinking and exposure keratitis, and second is retrobulbar neuritis. Especially for retrobulbar neuritis, we will have to use steroids to reduce the swelling and the inflammation component. In fact, in some cases, we have even used orbital radiation to shrink the mass, to shrink the soft tissue swelling which is present in this case. A mnemonic that can be used to represent all these manifestations of Graves' ophthalmopathy is called as no specs. Actually, the point is, you see, no specs per se, they are not going to ask you in the exam. They're just going to ask you rather what is the early manifestation, what's the late manifestation. The early manifestation is a sign. First, there is a sign, then is a symptom. You can definitely notice, I'm just zooming it once again. You can see initially there's a sign in the form of a lid lag or lid retraction. That's primarily because of the contraction of the Mueller's muscle. Then there is a periorbital edema. So no, then is soft tissue involvement. That's the that is gonna be the specs S alphabet that I have highlighted before you. Subsequently, coming to the P component, it will be proptosis. Then is extraocular muscle involvement causing a diplopia. Remember, inferior rectus. Then is corneal involvement, and lastly is a sight loss explained by two things: the corneal involvement as well as retrobulbar neuritis developing in the patient. Most of the time this is a bad finding, and most of the time I will also find that Graves' ophthalmopathy is more common in smokers and the prognosis is also bad. So if the question is describing a smoker with Graves' disease, I highlight the prognosis is bad, and the prognosis is bad not only because the person will lose vision. There's one more problem. In these patients, if you try to treat them with radioiodine, then they can actually worsen and can land up in thyroid storm. This is just epidemiological information I'm telling you. Smoker and Graves' disease together, they form a very bad combination in a sense that one, the person will have higher incidence of retrobulbar neuritis, and second, when you treat them with radioiodine, one of the methods of treatment of Graves' disease is radioiodine. So if you are using radioiodine here, actually they can land up in a thyroid storm. So most of the time, if ophthalmopathy is present, we avoid radioiodine for management of these patients. The clinical signs I'll summarize once again are mainly in the form of sympathomimetic stimulation. That's gonna eat up one or two lines in the MCQ. Then he's mainly gonna talk about myxedema. Subsequently, he's gonna talk about presentation of Graves' ophthalmopathy, and sometimes they could even be clubbing developing in these patients. For the clubbing, however, the technical term that the examiner will use will be Graves' acropathy or thyroid acropathy. You see, clubbing per se as a term is what we study with respect to, let me say, lung cancer or bronchiectasis or cyanotic heart disease or subacute bacterial endocarditis. So traditionally, clubbing is something that you always are going to read from CVS perspective or SP perspective. But today I'm teaching you endocrinological cause for clubbing, that is going to be Graves. Another disease that you read acropathy as a word can be acromegaly. So acropathy is what you read, again I repeat, in Graves as well as in acromegaly. In some cases, well, because this is per se a discussion for Graves, overall, if I look from the perspective, there could be surgical causes also. Now, a patient could also be having a multinodular goiter. And if it is a multinodular goiter, it is a distinct possibility that the goiter might become big, and in some cases might even have a retrosternal extension. So to check for whether there is evidence of retrosternal extension in the patient or not, I'll repeat my statement. I said I have a patient who's having hyperthyroidism manifestations, as you can see from the symptoms and signs. Now, I'm not at the moment aware whether the person is having Graves' disease because I've not done workup. It could also be a surgical cause. No, patient could be having features of hyperthyroidism, plus there could be retrosternal extension of the goiter. To diagnose that, what I'll do in this gentleman will be that I'll ask this person to raise his hands. Now see what happens. You definitely in this image can notice at least a thyroid mass in this guy. Now when I will ask this person to raise his arms, this thyroid mass, which is having a retrosternal extension, will press on the superior vena cava of the patient. Due to compression of the superior vena cava, you can notice that the entire face of this person will become tomato red. There is an extensive facial plethora developing on simple arm raising in this gentleman. The objective was to explain to you what we call as Pemberton sign. Pemberton sign is not going to tell you whether it's going to be hyperthyroidism or is it a hypothyroidism. It is rather going to tell you regarding a mass effect of a plunging goiter, plunging because it's going down into the chest, or instead of using the word plunging goiter, he might just say the word retrosternal extension of the goiter. I repeat the statement once again. This particular statement that I have made, Pemberton sign, does not talk about hyper or hypo per se, because even in hypo, you could be having goiter as a presentation. Goiter can be euthyroid, goiter can be hypothyroid, goiter can also be having a hyperthyroid presentation. I mean, you can't predict. Obviously, the commonest one is euthyroid. I agree to that. So the point I'm trying to make is that this is just going to represent the extension of the thyroid gland in the patient. We will now discuss what is going to be the workup for these patients of hyperthyroidism. The first test that I'm going to do for this patient is a thyroid function test. Ideally, we should be having the entire report with us, that is total T4, total T3, free T4, free T3. In the exam, if they ask you that what is the minimum tests that are required for diagnosis of this patient, then the minimum tests that are required are values of free T4 and TSH. When I evaluated the report, I found that total T4 and total T3 in the person was increased. Free T4 and free T3 was also increased. You see, if I have to select one, why I'm saying T4 is because T4 is the main produce of the gland. That is why I first wrote if free T4 is increased, because there could be situations where total T4 may be normal but free T4 is increased. Please appreciate that thyrotoxicosis as a term is used when free value, the unbound form I'm talking about, is increased. I shall now be doing TSH in the patient, which is an important part of the diagnostics. There can be two possibilities. Either the TSH of the patient can be undetectable or it can be grossly elevated. If you read about a situation where the TSH of the patient is severely reduced, it means the fact that the patient is suffering from Graves' disease, or the technical word is primary hyperthyroidism. On the other hand, if it is elevated, rarely it can be normal also, then it is going to be suggestive of the fact that patient is having a pituitary adenoma. You see, pituitary adenoma initially may not be having a very significant spike in the value of TSH, though T4, T3 are substantially increased. Pituitary adenoma will be classified as a secondary cause. Therefore, the test that I will do in the patient would be a MRI head. You see, why I'm calling this discussion or this particular part of discussion important is because majority of questions you will have to answer the treatment based on the lab report. If you find TSH undetectable, and he says what is the next best investigation for the person, then I will say that I would like to go in for evaluation of thyroid stimulating immunoglobulin. Instead of writing thyroid stimulating immunoglobulin, he might write the technical term TBII, that is thyrotropin binding inhibitory immunoglobulin assay. It basically means that we are picking up TSI in the patient. But if it's gonna be secondary, then the next best investigation for the person will be a MRI head to pick up whether it's a micro or a macro adenoma in a patient. The treatment will also vary. If it's going to be Graves, we are going to use either drugs or radioiodine or surgery. But if it's going to be a pituitary adenoma secondary cause, we will plan a transsphenoidal surgery for the patient. The answer in the question will be dependent upon whether it is primary or secondary hyperthyroidism. So values of TSH should be scanned very carefully. Assuming the fact that the patient is not having Graves' disease, there could be a surgical cause. So we would be running a thyroid scan. The interpretation of thyroid scan I have already highlighted in the earlier part of the discussion. I'll just show you the image once again for the thyroid scan. In Graves' disease, obviously it will be a diffuse uptake that is increased, but in multinodular goiter, you will notice some focal areas where there is an increased uptake present. Do remember the fact that cold nodules, well, it's dangerous because cancer, I said, is cold. So cold nodules will obviously make you be a little more careful about this person. Why? You are already careful, a little more careful because you are thinking about possibility of a malignancy. In a thyroid scan, increased uptake can be either due to Graves' disease. In a thyroid scan, the uptake can definitely be increased with respect to Graves' disease or multinodular goiter. Whereas if the uptake is reduced, then there's a possibility that there must be some destructive process going off in the body. What I mean by destructive processes, the person could be having thyroiditis of various etiologies, because thyroiditis initially can present with hyperthyroidism. To identify the mass effect of a goiter, a ultrasound of the neck or a MRI of the neck can be done. These are 5 investigations which are required, but most of the time we don't need to require all of these investigations, primarily because the diagnosis is very clear. If free T4 is gonna be grossly elevated and TSH is undetectable in a patient. For the sake of multiple choice questions, remember, if they give you a scenario of free T4 being normal, free T3 also being normal, but the TSH of the patient is extremely low, then this report will be answered by you as subclinical hyperthyroidism. I know the fact that you guys are more comfortable with the term subclinical hypothyroidism, but from the exam perspective, I am also teaching you about this term subclinical hyperthyroidism. Well, this discussion explains why TSH is called as the best thyroid function test, because it can help you identify the subclinical process. And as the disease will progress even further, then the values of free T4 in the person will begin to reduce. Once we get the workup in place, mainly between the primary and the secondary ones, our job would be next to plan the treatment of this patient. From the treatment domain, there is a slight controversy with respect to what is done in America and what is done in Japan or in Europe. I'll try to explain it from the American perspective. Please appreciate the fact that Graves is an autoimmune disorder, so therefore it will have a waxing and a waning course, and there is a distinct possibility that patient might actually be off medication intermittently during the course of the disease, like you're monitoring the patient for 10 years. So in between, you might even have to stop the medication. There is a distinct possibility that in Graves' disease, there can be a spontaneous relapse and then a remission, as is true for any autoimmune disorder. So that has to be kept in mind. In fact, there is also a possibility of fluctuation, because if it is a destructive thyroiditis occurring in a patient, you see the discussion that I'm doing here is not only peculiar to Graves, it could be thyroiditis component also. No? So in a thyroiditis component, there could be a fluctuation that initial presentation of the patient, the free T4 is elevated, and in the same patient after a couple of years, the opposite might happen. The hypothyroidism manifestations will occur, free T4 will be lesser in the patient. So this gross change from hyper to hypo is possible with destructive thyroiditis. As far as the ophthalmopathy component is concerned, it is going to be worse off in cigarette smokers and can even cause loss of vision. So we always have to be ready with steroids, that is methylprednisolone. The course of ophthalmopathy is that initially, even when you start the treatment, initially it will worsen. For the first 3 to 6 months, the ophthalmopathy component, once it develops, the course will worsen. Then the course will remain static. Next about 1.5 years, about something like 18 months or so, there's a possibility that the disease might remain the same, and then the disease might actually improve also. So improvement is possible in ophthalmopathy also, but as I explained to you, in some cases, especially cigarette smokers, it can be so nasty, it can just take off vertically and a person might be having loss of vision. Now comes the important question: what is the treatment of choice for managing a patient of Graves' disease? And it's controversial because different countries have different rules. We'll follow what Harrison says for America. The treatment of choice for Graves' disease would be answered as radioactive iodine. I would like to go in for a iodine 131 based thyroid ablation. It is relatively easy because you have to give this radioactive iodine orally to the patient. We just make the patient drink this radioactive iodine, and this will be concentrated in the thyroid gland. It will be producing beta rays, and these beta rays will make the person radioactive. So obviously the patient has to be kept away from children in the family. The patient has to be kept away from other pregnant ladies in the family. The T half of this is 8 days. Radioactive iodine is contraindicated in case the patient is planning a pregnancy or is already pregnant. It's contraindicated if the patient is breastfeeding a baby, because you don't want to harm the child. But otherwise, as such, this would be the best way, because it is ease of administration that helps in managing this case. Coming to the important question, what is the treatment or choice for Graves' disease? Then the answer will vary upon country to country. Like in Europe, they usually prefer anti-thyroid drugs and surgery, whereas in America, they prefer radioactive iodine. I'll go by the American method. That is because that is first given in Harrison, that it is radioactive iodine, which is the treatment or choice for Graves' disease. The isotope we shall be using here is iodine 131. I have explained to you that for diagnostic purposes, we can be using iodine 123 and 132. But iodine 131 is preferred for ablation. The total half-life of this would be 8 days, and it will help in producing beta rays, and these beta rays will then be ensuring ablations. So definitive improvement in the condition of the patient can be seen. Obviously, we need to prepare the patient. Anti-thyroid drugs have to be given initially to stabilize the case, but if the questions just specifies one-liner, what is the main treatment for Graves? According to Harrison, in America, what is recommended is radioactive iodine. Another approach is that we can start the treatment with anti-thyroid drugs. If the patient has control of symptoms with anti-thyroid drugs, good. But if there is a relapse, there is worsening, no improvement, then you can go for radioactive iodine. So one of the indications of radioactive iodine is poor response to anti-thyroid drugs. Well, anti-thyroid drugs, there are two of them, the important ones which are asked. One is propylthiouracil and the other one would be carbimazole and its derivative methimazole. If the question just says what is the drug of choice for patients of Graves' disease, if they have to or you are forced to give a single best answer, then the single best answer would be methimazole. Let us see why. Propylthiouracil is a very good drug. It is safe in the first trimester, whereas carbimazole is safe in second trimester or is preferred in second trimester. Why? Because carbimazole per se, if it is given in the first trimester, it can cross the placenta. It can go to the baby and the baby will develop hypothyroidism. Well, I don't want the baby to suffer. So when it comes to carbimazole, methimazole, they are preferred in second trimester because now the organogenesis of the baby has already occurred. So the main reason why carbimazole is not given in the first trimester is the teratogenic effect that it can cause. In fact, it can be more than one effect also. One of the important teratogenicity that is asked is a defect with respect to the skin, that is aplasia cutis. Next, what I'm saying is optional for you. If you want to note it down, it is okay. But even if you don't note the next two ones down, it is still, I mean, you can still go ahead with the question, because the next statement of mine-guanal atresia is also a teratogenic manifestation seen with carbimazole, methimazole, but it is less commonly seen. So two of them, but aplasia cutis is the one that is asked. When I speak like this, a lot of young doctors, they message me. They say, sir, carbimazole you are giving in the second trimester. You are not giving it in the first trimester because it is teratogenic, but you're still calling it a drug of choice. Well, why am I calling it drug of choice? Is because if propylthiouracil is given all through the pregnancy. You see, the query is, and it's a logical one. Most students say that, sir, if you're giving something in the first trimester, that should be the drug of choice because it is not harming the baby. So why are you not continuing propylthiouracil in the second trimester and in the third trimester? Logical question. Oh, if you can give in first, why not second? You will notice that propylthiouracil tablets are having a marking and the box is also having a black box warning. What I imply by black box warning is that the label categorically says that long-term usage of this drug can contribute to hepatotoxicity, and in pregnancy we anyway can have fatty liver pregnancy. So we don't want to take in a chance. Get both the perspectives right. Point number one, in first trimester, propylthiouracil is safe because it is not going to go from the mother to baby, so that point is okay. Why are you not giving it in the second trimester? Why are you not giving the third trimester? Hepatotoxicity. In contrast, carbimazole, methimazole can have teratogenicity in the form of aplasia cutis or guanal atresia. So both of these, I mean, are the ones which are to be remembered. On the other hand, radioactive iodine, well, problems are if a lady is pregnant, if there's another lady pregnant in the house and this lady is given radioactive iodine, if she comes in contact with the other baby, this lady is radioactive. So avoid contact with children and another pregnant lady per se to prevent the radioactivity induced damage. The surgery that can be done in these patients would be total thyroidectomy. Well, there's a shift in policy. When I was a student your age, when I used to read Bailey's and Love edition, then Bailey and Love at my time used to say it is subtotal thyroidectomy that is preferred. But in the current edition of the textbook, both Bailey as well as in Harrison, it is mentioned that there's a policy shift and now most surgeons prefer to go for total thyroidectomy over subtotal thyroidectomy. Do remember the fact that all these aspects that I've highlighted before you are for a patient in whom TSH is undetectable, that is Graves' disease. On the other hand, it should not happen in the exam that you did not take care of the fact that TSH of the patient was grossly elevated. The patient was actually having a pituitary adenoma. Yes, if a person is having a pituitary adenoma, you can use antithyroid drugs to stabilize the patient, but that will only be symptomatic control, na? But you are not treating pituitary adenoma by antithyroid drugs. So antithyroid drugs can be used both in primary as well as secondary. But the point is, for a person having a pituitary adenoma, you need to get rid of the tumor. Otherwise, it will also start producing mass effects. So that would be a transsphenoidal surgery. So do take care of the fact that TSH value in the question in Graves' disease as well as in discussion of hypothyroidism, TSH value will be integral for your answers in the question. When it comes to drugs like carbimazole and methimazole, one of the advantages of carbimazole methimazole is that they can be given on long-term basis because they do not have hepatotoxicity. But still there's a problem. Regularly complete blood counts must be done because you would have read about this question, dose limiting side effect of antithyroid drugs. I'm just giving a general statement. Dose limiting side effect of antithyroid drugs is, and this would imply that you might have to discontinue the medicine. Lots of time, if this side effect will develop in a person, you will have to stop medicine and tell the patient that I'm referring it over to a surgeon because you need a surgery because the drug maximum dose I've already reached and now it's causing this problem of suppression of your WBC count, which makes you susceptible to infections. Dose limiting side effects. Standard side effects are like nausea, vomiting, rash. That can easily be managed. But if it is going to be dose limiting side effect in the form of agranulocytosis, that means that the dose has to be reduced and in some cases totally stopped, and you need to use an alternative method for managing the patient. 3 points that I want to highlight at the moment is, if he says treatment of choice, the answer is radioactive iodine according to American protocol. If he says what is the drug of choice for this condition, it is methimazole, carbimazole. I mean, we'll answer one. Propylthiouracil, why it is not used, I've already explained to you. The black box warning due to hepatotoxicity. The surgery of choice for this patient should be answered as total thyroidectomy over and above near total and subtotal. Even near total, subtotal is also given, but then they are mentioned subsequently in the textbook. So if you get these issues right, then you would be definitely in a position to get these questions of Graves' disease right. I shall now be comparing this discussion of hyperthyroidism with the counterpart opposite effect, that is hypothyroidism. The discussion will be divided similarly into two parts, that is primary versus secondary. Let's work out the causes and the laboratory reports seen in these patients. Primary would imply that the problem lies in the gland of this patient, whereas secondary would imply that the problem lies in the pituitary. Well, if the gland will malfunction, then the production of T4 and T3 both will be reduced. And by feedback mechanism, the TSH of the patient will start getting elevated. On the other hand, when it comes to secondary, the main problem will be damage to the pituitary. The end result will be decrease in the production of thyroid stimulating hormone. If there is less thyroid stimulating hormone, there would be less T4 as well as less T3. So you will notice that the direction of arrows in the report in secondary is always going the same way. If you are listening to this discussion carefully, please appreciate that in secondary hyperthyroidism, TSH, T3, T4 all were elevated here, all three are reduced. So if you just get the direction of arrows right, you would definitely be able to get the treatment of choice right. I would also like to tell you that rarely in a multiple choice question, the TSH values may be normal, and along with this, the T4 and T3 values will be less. Now, when I describe this particular part where I put a star mark, the query or messages that I get from a lot of students is that, sir, how is it possible? I mean, on one hand, you are saying TSH is normal, then why should there be decreased production of T4 and why are you calling it secondary? You see, if the gland is not working, T4 should be less, T3 should be less because T4 is get converted into T3 in the blood, then TSH is normal. Why are you calling it secondary? I want to tell you that there is a distinct possibility that the pituitary of this patient is producing TSH which is biologically inactive. Looks very surprising, no? Biologically inactive TSH, it is produced in normal amount. You see, the problem can be either of quantity or quality. The quantity is perfectly fine. I repeat my statement. Quantity is fine. Quality is bad. So you are having a poor quality TSH in a sense that amount wise it is okay, but quality wise it is defective, so it's not going to be able to cause an optimal stimulation because the quality is bad, and therefore the T4 and T3 values can be reduced. Remember the fact that in secondary hypothyroidism, if it's a poor quality TSH being produced, what I mean by poor quality, the casual word is biologically inactive TSH, it will not be able to cause a proper stimulation. That is why T4, T3 values are reduced. So I hope that explains the perspective. One of the leading causes of this would be iodine deficiency disorder, both in I would say developing world and also in the developed world. In most of the countries, iodine deficiency is very prevalent. And if a girl is iodine deficient at the time of pregnancy, you see, endemic goiter will usually first present at the time of puberty and then at the time of pregnancy. And if a woman is living in an iodine deficient area, she'll definitely have a thyromegaly and she will not be able to provide iodine to her baby. So the baby born to this lady will also be having hypothyroidism since birth. I can just use an alternative term here. Just pay attention to this terminology. Lots of time in pediatrics, you would have read the term congenital hypothyroidism. If the question simply says, what is the leading cause of congenital hypothyroidism, then do not answer iodine deficiency. Iodine deficiency disorder is obviously prevalent all over the world. But if the question says, what is the cause of congenital hypothyroidism, your first answer would be thyroid dysgenesis, which implies that the thyroid gland is not properly developed. The next important cause can be thyroid dyshormonogenesis, where the gland is present but it is not able to produce good quality hormone. Dyshormonogenesis, the hormone is produced maybe biologically inactive, both T4 and T3. The third possibility is that the mother is living in an iodine deficient zone. If she does not have iodine for herself, she cannot provide iodine to the baby. So the baby born will be having a iodine deficiency or less production of T4 and T3, or in a sense a primary hypothyroidism, which is called as endemic cretinism. Cretinism not only will have a short stature and a mental retardation, but it basically means that the child is hypothyroid right from the first day of life. The most common cause for congenital hypothyroidism, as has been explained to you, is thyroid dysgenesis, and then is iodine deficiency, which is written as endemic cretinism. Coming back to the internal medicine domain, I have highlighted that in iodine deficient areas, obviously primary hypothyroidism will occur. But in India, especially because the government of India has been very aggressive with usage of iodized salt. Therefore, in Southeast Asia, in a lot of countries, iodine deficiency has almost been eradicated, at least in India. So what would be the important cause from Indian perspective where iodine deficiency is not there? You see, if you go to hilly areas, things might be different. But otherwise, at least I can talk about urban India. All of us eat Tata salt, iodized salt. So in urban India, getting iodine deficiency is really, really rare now. In those circumstances, if he talks about iodine replete area, then it is Hashimoto's thyroiditis, which is an autoimmune thyroiditis contributing to primary hypothyroidism. Rarely he can also speak about food goitrogens. Well, what are the food products, intake of which on long-term basis can be responsible for hypothyroidism, because they will interfere with the organification process of the reactions that occur in the thyroid gland and help in synthesis of T4. So cabbage and cassava, right? The same cassava beans that you read in G6 PD deficiency also, the same ones coming up here also are referred to as food goitrogens. Then even drugs can contribute to hypothyroidism. One of the drugs notorious for this is amiodarone. Amiodarone can cause both hypo as well as hyperthyroidism. So do remember the fact both hyper and hypo can be associated. On the right hand side, on the other hand, I would say more conventional answers are present. Like the patient could be having Sheehan syndrome, that is a postpartum hemorrhage contributing to anterior pituitary destruction. If it is a non-obstetric cause of damage to the pituitary, we will use the word Simmons disease. The reason for Simmons disease could be rupture of arteriovenous malformation. It could be a tumor. It could be, let me say, high blood pressure. So AVM, tumor, hypertension are the reasons which will contribute to this. Then would be cranial irradiation. You see, this patient has received cranial irradiation for some other reasons, let me say metastasis, but then this could damage the pituitary. Non-caseating granulomas of sarcoidosis can contribute to neurosarcoidosis. It can contribute to cranial palsies, and if the non-caseating granulomas are in the area of the pituitary or adjacent to that, then there could be damage to pituitary resulting in this profile. Similarly, iron toxicity. Traditionally, hemochromatosis is what causes bronze diabetes, but today I'm saying that it can even contribute to damage to the pituitary. So when it comes to secondary causes, I mean, when you read these causes, no, I usually do not find people making any mistakes. But for the left hand side, the mistake that I usually find is one, if they ask you about congenital hypothyroidism, don't answer iodine deficiency because we are programmed for it. He knows that. So the answer is thyroid dysgenesis. And if he talks about iodine replete area, like India per se, iodine deficiency disorder has been eradicated. So in India, the current cause is not iodine deficiency, it is Hashimoto's thyroiditis, and this would have been even corroborated by the PSM doctor as well. Once we get the causes right, I'm next gonna explain to you how the clinical features of this disease will evolve. Since the thyroid hormones play an important role in basal metabolic rate, the basal metabolic rate in this case is downgraded, so there would be a weight gain in the person. However, it is not an extensive weight gain, it's only a modest weight gain that will occur in the patient. Unlike Cushing syndrome, where patient will put on lots and lots of fat and a centripetal obesity, here the weight gain is relatively on the lower side. The calorigenesis component will also be reduced, so that is why the patient will not be comfortable in the winter months. Cold intolerance. The moment these terms are written, it is very unlikely that you will ever mess up on the clinical diagnosis of hyper and hypothyroidism the way the question is presented. Myxedema is an integral component of both hyper as well as hypothyroidism. In hypo, it can occur over the scalp. Therefore, you will notice significant alopecia. Let me say, female patient, she's combing her hair, brushing her hair, she's losing a lot of hair. You see, glycosaminoglycans, which are present in the myxedema component, they tend to trap a lot of water. Therefore, there would be swelling in the tissues. So therefore, myxedema, if it is going to involve the face of the patient, you will read about puffy face. That's going to be a cosmetic complaint of the patient. If the myxedema involves the vocal cords, there would be a voice change. There would be hoarseness of voice, or if you are speaking to this patient, let me say over a telephone, it will sound like a man's voice, like a woman's voice will become very throaty and heavy, so it will sound like a man's voice. There is an upgrade of total peripheral resistance. So the blood pressure of this patient is elevated, and when you take the BP recording, you will be surprisingly finding systolic to be normal and diastolic to be elevated. You will be finding isolated diastolic hypertension. The statement of mine is isolated diastolic hypertension is found in hypothyroidism. That does not mean that it is one of the common causes. Obviously, if they ask you what causes isolated diastolic hypertension, the first answer is essential hypertension. If that is not present, though it's the commonest one, then it is what we are talking about, hypothyroidism. Apart from this, you will also read about isolated diastolic hypertension developing in Conn syndrome and even in Cushing syndrome. The number one cause I've highlighted is essential hypertension. It's obviously a diagnosis of exclusion. I mean, hypothyroidism, Conn and Cushing has to be reduced in these patients, and hypertension per se is going to contribute to headache on a daily basis. The person might ascribe that to office stress. There will also be an increase in gut motility of these patients there will also be a change in the gut motility of this patient, which will explain the constipation component. Traditionally speaking, whenever you read about thyrotoxicosis, there is an increase of sympathomimetic stimulation. So logically, constipation should be present in Graves' disease. But here I'm describing to you constipation and hypothyroidism. Why? Because the myxedema component tends to slow down the gut motility. That also leads us to the fact that why do you get diarrhea as a symptom in patients of hyperthyroidism? That's a very common query that I get from a lot of students over email or WhatsApp or over social media. So I would like to highlight here the fact that why do you read diarrhea as a symptom in hyperthyroidism? I did not mention it earlier because I wanted to bring this fact or debate this point with you, that why do you get constipation in hypo and why do you get diarrhea in hyper? So let's have a analysis here. You see, the basic problem in people with hyperthyroidism is that they're losing weight, so they'll try to obviously eat more also. You see, when you're hungry, carbohydrates, they produce a filling effect in our stomach. So because of the fact that this patient of hyperthyroidism is more hungry than normal and is loading himself with carbs, so carbs would contribute to osmotic load in the gut. This osmotic load can draw in water, that can explain the diarrhea component. The second thing is that because sympathomagnetic stimulation will slow down the gut motility. Now listen to my words very carefully. He says the fact that in hyperthyroidism patient, the sympathomagnetic stimulation, you are aware, vagus will accelerate the gut motility, sympathomagnetic slow down the gut motility. This slowing down the gut motility will increase the bacterial load. And now you can see two things together. Sugar is there unabsorbed and bacterial load is also increased in the patient. So this bacteria will break down these products, the osmotic products, into molecules that will further draw in water, and the osmotic diarrhea component can develop. Studies have also shown that hyperthyroidism also affects bile acid metabolism, and bile acids are responsible for emulsification of fat. So there are multiple reasons why diarrhea can be present. I repeat the features once again. One of the standard features would be the person is having a sense of increased hunger. So to satiate it, he'll eat more roti or more rice. And rice and roti, that is wheat, will be having more carbohydrates. So more osmotic load in the gut. The gut motility is reduced. So therefore the bacteria in the intestine, they will have more time to degrade all those products. So a lot of osmotic processes going on. Plus bile acid metabolism is also hampered in this patient. So all these features explain diarrhea in a person of hyperthyroidism. I mean, the query that most students sent was that in hyper, because there is a slowing of the gut motility, then it should cause a constipation. No, slowing of the gut motility is rather contributing to increase of bacterial load plus the osmotic component coming up. So the two together can explain the diarrhea component. On the other hand, in hypothyroidism, I again wrote slowed gut motility, but the reason for that I've explained is the myxedema part, the myxedema that can involve the intestines also. Most of the time, the symptoms that are given in hypothyroidism are easy to identify. In a female patient, menstrual abnormalities can be described in the form of menorrhagia. Don't be under impression that only menorrhagia seen in hypothyroidism. It can even be oligomenorrhea. I'm talking about the common presentations here. Depending on the age of presentation, it could also be primary or secondary infertility described in the question. Neurological features can rarely develop in hypothyroidism patient. There are two reasons for neurological deterioration in hypothyroidism. One is myxedema coma. Now, as the name suggests, coma, so that will obviously have neurological features. I'll be explaining myxedema coma towards the end of this discussion or lecture. At the moment, I want to also incorporate in the symptoms of this patient a very peculiar neurological presentation of uncontrolled hypothyroidism caused by Hashimoto's thyroiditis, called as Hashimoto's encephalopathy. Well, the neurological presentation of this would be involuntary jerks of various muscle groups. You see, in GTCS, whole body will be jerking. In focal seizure, one arm would be jerking. But in myoclonus, it is only few muscle groups which are having involuntary jerking movement. So myoclonus can also be written in MCQ in symptoms of hypothyroidism. That is, myoclonus is a presentation of Hashimoto's encephalopathy, where hypothyroidism would be present in the patient. Along with this, in this patient, EEG will reveal presence of slow waves. The slow waves I can make you remember from neurology component are like delta waves present. The surprising thing about Hashimoto's thyroiditis is that it does not respond to anti-thyroid drugs. The surprising thing about Hashimoto's thyroiditis is that it does not respond to levothyroxine supplementation, but it is surprisingly steroid responsive. So there are 3 points for Hashimoto's thyroiditis. That is only that you need to remember. Myoclonus, there could be slow waves in the EEG like delta waves, and it is steroid responsive condition. And because I'm describing symptoms of hypothyroidism, so myoclonus also has to be kept in mind. We will now compare this with examination findings of hypo versus that of hyper. So like when I described hyperthyroidism to you, I described early finding as increase in sleeping pulse rate, and I described resting tachycardia, sinus tachycardia, and even a arrhythmia. In this case, the question will say what is the reliable examination finding of hypothyroidism? Well, there will obviously be bradycardia, there would be hypertension, but the reliable finding that is to be answered is hung up ankle jerk. You see, you would have all illicit ankle jerk practically. The root value is S1. In this case, there is myxedema of the Achilles tendon. Because of the myxedema of the Achilles tendon, the relaxation phase of the deep tendon reflex in this case is slow. Since I said the relaxation phase is relatively slow, that is why it is written hung up ankle jerk. Do not mix it up with what I've described in neurology as hung up reflexes. There are two separate terms I've said: hung up reflexes, hung up ankle jerk. Hung up reflexes is a feature of chorea. It could be Sydenham's chorea, it could be maybe Huntington's chorea, but do remember this subtle difference. Hung up ankle jerk is hypothyroidism, the delayed relaxation phase due to myxedema of the Achilles tendon, and hung up reflexes is a feature that is seen with chorea where caudate nucleus in the patient is damaged. In the vitals, you will always notice that the heart rate of these patients is less, but the blood pressure would be elevated, and most of the time it is going to be a isolated diastolic hypertension. That does not mean you can't have a systolic, but this is very peculiar a terminology, no? Diastolic hypertension, so that is why it has been highlighted here. Cosmetic problems from the skin domain can be expected in the person, that is coarse, dry skin. It will be actually a thick and a coarse and a dry skin. The patient will say, I'm trying to use multiple moisturizers to no effect. The skin will look unhealthy also. Why does it look unhealthy is because you see traditionally when we eat vegetables like carrot etc., they contain beta carotene, and beta carotene is converted into vitamin A. Now thyroid hormones are required for conversion of beta carotene into vitamin A. If T4 is not there or is less, then the conversion will be lesser, and therefore in the patient beta carotene will accumulate. This beta carotene will be responsible for giving the yellow appearance of the skin of this person. So this hypothyroidism patient came to you and he or she said that, sir, am I having jaundice? Because the skin was relatively yellowish in a fair skinned person, the skin was looking unhealthy yellow. You thought maybe there could be icterus, so you decided to check the white of the eye, the sclera of the patient. You will notice that in jaundice or in icterus, the skin is yellow and the sclera is also yellow, but in this case you will notice the skin is yellow but the sclera will be normal. So you can differentiate from the jaundice or icterus that you see with viral hepatitis versus what I mentioned here, that is beta carotenemia. For the next manifestation, I would like you to listen to me first and then I'll note down or jot down the information. Let us assume this to be the anterior pituitary and the posterior pituitary. One of the hormones that is produced here is thyroid stimulating hormone, and the second one that is produced is prolactin, and the control over this is from TRH. For the next point, I would like to give a short explanation and then you can note down the clinical feature. You can take this to be representation of the anterior pituitary and the posterior pituitary. The anterior pituitary will release TSH as well as another hormone that is prolactin, and the main hormone which is regulating all of this is TRH, thyrotropin releasing hormone. Now TRH acts on the anterior pituitary and it causes release of these two, that is TSH as well as prolactin. Let us assume we are talking about a patient who's living in an iodine deficiency area. The person is suffering from iodine deficiency disorder. Therefore, the production of T4 from the gland and T3 will be less, and what's going to happen by feedback? TSH and TRH will increase. In this particular patient, there's going to be a positive feedback provided both to the hypothalamus as well as to the pituitary. Due to the positive stimulus, TRH will rise. Now TRH is doing what? It is causing production of two hormones now. So TSH will rise obviously, but similarly prolactin will also rise now. And this prolactin will go and act on the acini of the breast and will contribute to manifestations of galactorrhea. Though this symptom is written towards the end in multiple choice questions, lot of time you will notice that he would love to ask you regarding the presentation of galactorrhea in hypothyroidism. The logic behind this is that TRH controls the release of both TSH and prolactin. So if TRH is more, and reason for TRH more is positive feedback of iodine deficiency. If TRH is more, the values of TSH and prolactin will dramatically rise to the level that there could be galactorrhea occurring in a person. From the exam perspective, what I've tried to explain to you here is that galactorrhea is a presentation of primary hypothyroidism. Remember, I told you iodine deficiency implies primary hypothyroidism in a patient. Traditionally, you read about galactorrhea with a tumor called as prolactinoma. You also read about galactorrhea with chronic renal failure. Why? Because in chronic renal failure, prolactin cannot be excreted. You see, prolactin is excreted by the kidney. If the kidney will malfunction, prolactin is not normally metabolized, so the values tend to become relatively higher. Do remember the fact that you are not going to have galactorrhea in secondary hypothyroidism. Secondary hypothyroidism would mean pituitary is damaged, so TSH and prolactin both would be lost. I hope you recall secondary hypothyroidism. Here I imply Sheehan syndrome. Sheehan syndrome per se, when you look at it, Sheehan syndrome per se will be a condition that will be having rather a presentation of failure of lactation. So you can see that I have created a question for you with 4 options. The top 3 conditions are the ones which are contributing to galactorrhea. Whereas galactorrhea will not be encountered in, the answer is secondary hypothyroidism. Why? Because of the fact that the values of TSH in this condition as well as prolactin in this condition is less because the anterior pituitary is busted. You see, there's an anterior pituitary infarction. From the exam perspective, if they ask you what is the most reliable clinical sign for identification of hypothyroidism, then the answer should be given as hung up ankle jerk. Whereas in hyperthyroidism, the early, I'm not saying very reliable, but yes, one of the important features that helps you pick up the disease along with other features is increase of sleeping pulse rate in the patient. Coming to the workup of these patients, again the main test to be done in the patient is values of free T4 and TSH. As I've highlighted, TSH is the best thyroid function test, and along with this, if you check the free T4 values, the T4 values will be substantially reduced in the patient. Ideally speaking, when I look at the values of total T4, total T3, then if I look at the values of free T4 and free T3, then all of these should be reduced. But the point of mine is that I don't need to do all of these just for the cost benefit ratio. If the main produce of the gland, that is free T4, is hampered, it means hypothyroidism. I mean, meaning of the word hypothyroidism is not total T4 reducing, it is free T4 that is lesser. TSH values, however, can either be more or can be less. There are 2 possibilities in the multiple choice question. One is that the TSH values will be definitely elevated. The moment you read elevated TSH, it means the patient is suffering from primary. Whereas if the TSH values of the patient are reduced to normal, it means it is secondary cause where there is a destruction of the pituitary of the patient. Now do remember the fact that if in the question he is giving you this report that the TSH of the patient is substantially low, in those circumstances, the next best investigation will work out to be MRI head. If you are listening to me carefully, you will notice the fact that MRI head is the answer for both secondary hyperthyroidism as well as secondary hypothyroidism. So that takes the pressure off. For primary, we are talking about, let us say, Indian situation where Hashimoto's thyroiditis is prevalent. In those circumstances, I need to pick up antibodies, no? So you are familiar with the fact that in Hashimoto's thyroiditis, the antibodies present are anti-TPO, that is thyroid peroxidase antibody, as well as anti-thyroglobulin antibody. I repeat the statement, TPO is thyroid peroxidase, TG is thyroglobulin antibodies, which will help you identify that yes, this person is having an autoimmune process contributing to the damage to the gland. I can just put numbers here. I will be doing a thyroid function test in this person, that is TFT. For cost benefit ratio, there is a possibility that I may not run all of these tests. I will simply be running a free T4 and TSH, and that is sufficient for me to identify the disease. In majority of cases, only these 2 tests will help you narrow down to the etiology. Because goiter can be having euthyroidism, hypo and hyperthyroidism. We are talking about hypothyroidism at the moment. I will also preferably do a ultrasound or if possible a MRI neck to check for any extension of the thyroid into the retrosternal space that can contribute to Pemberton sign, and compression superior vena cava is obviously going to contribute to even a positive Kussmaul sign in this person. The 5th investigation that I'm saying is usually neglected by most doctors, so please listen to this initially. Hypothyroidism will contribute to myxedema, lymphedema, and this lymphedema can occur even outside the heart and can occur outside the lungs, contributing to pleural effusion and pericardial effusion. This term that I'm writing before you, serous cavity effusions, is read by you 2 times in medical literature. One, you will read about this term in SLE. SLE causes serous cavity effusion. Second time you will read about serous cavity effusions in hypothyroidism. What is happening in these patients is that the lymphedema component / myxedema component is involving the pericardial space or the pleural space. I can casually call the discussion as myxedema heart for point number 5 in the workup of this person. Let us assume that this lymphedema is causing 20 ml of lymphatic fluid to accumulate around the heart of this person per year. Don't note down, just listen at the moment. Let me say the extra lymphedema means extra lymphatic fluid. So this extra lymphatic fluid is about 20 ml extra has accumulated. I'll just put plus sign here to say that over and above normal pericardial fluid is 20 to 50 ml for lubrication. In this person, the pericardial fluid is increased because of the lymphedema component. So let me say instead of 50 ml, it is increased to 70 ml on the first year, from 70 to 90 ml subsequently. So let us say over the course of next 10 years, or let me say over the course of next 15 years, the amount of fluid will accumulate extra. That would be about 200 to 300 ml. What I want to teach you here is not mathematics. I want to teach you here is that hypothyroidism patients, if untreated, can develop massive pericardial effusions. This massive pericardial effusion could be written in the question in the form of a ECG finding. One of the ECG findings that have been dealt or discussed in cardiology section is low voltage ECG. Obviously, the fluid will cut off the voltage, the electrical component. Another ECG finding of pericardial effusion, which is large in size, is electrical alternance. Either of the two can be written as maybe a C or a D choice in a MCQ of hypothyroidism. So I just want you to be remembering this statement. You will also notice that I used the word massive pericardial effusion. I did not use the term cardiac tamponade. In cardiac tamponade also, no, the fluid can be 200-300 ml. I did not use the term cardiac tamponade because cardiac tamponade takes a relatively very short time to put pressure on the heart, like trauma to the chest, right? There could be blunt trauma to the chest, or the person was not using a seat belt and the chest slammed into the steering wheel in a car accident. So the point of mine is that in cardiac tamponade, the pressure on the heart will develop in a short period of time. That could be minutes, hours, days, or weeks, but never years. If the pressure is going to accumulate around the heart over large number of years, gradually over large number of years, then because the pressure is gradually increasing over the heart will adjust its pressure. The heart will also adjust, accommodate this increasing pressure, and therefore pulsus paradoxus will not be present. See guys, from this discussion, I basically wanted to explain to you, one, pulsus paradoxus is a feature of cardiac tamponade. Cardiac tamponade develops fast, whereas massive pericardial effusion will take 15 years, 20 years to develop. So it's a gradually increasing process. So the heart will adjust to this gradually increasing pressure, and therefore pulsus paradoxus will not be present. Pulsus paradoxus is what you get in cardiac tamponade, but not in massive pericardial effusion. This discussion of point number 5 can itself be an MCQ, or it can be a part of an MCQ. I am putting the heading of mixed edema heart air, which incorporates the following findings. Over and above this, cardiovascular system is involved in hypothyroidism also because there can be a deranged lipid profile. In fact, the values of cholesterol can be substantially elevated in hypothyroidism patients, which can actually be missed, and they may not be started on statins, contributing to heart disease and maybe triple vessel disease. The term I want you to remember here is accelerated atherosclerosis. Diabetes mellitus also causes accelerated atherosclerosis. In diabetes mellitus, the main reason for accelerated atherosclerosis is hypertriglyceridemia. It's mainly triglycerides that are elevated in diabetic, but in patients who are suffering from hypothyroidism, it is mainly cholesterol elevation that will explain this. From the heart perspective, there can be a massive pericardial effusion. ECG findings can be given. Atherosclerosis manifestations might occur in the patient in the long run, or in fact, one more method of describing this massive pericardial effusion can be that if you run an X-ray chest of this patient, then either he can write increased cardiothoracic ratio. Anyway, the cardiothoracic ratio is increased in hypertensive patients, no, because there is increased load on the heart. Apart from this, another reason why cardiomegaly might be described in a multiple choice question is because there is fluid outside the heart. So I'm writing the classical term for pericardial effusion, which is large in amount, that is water bottle heart or money bag appearance. Any of these terminologies can be written in a question, and he's trying to distract you into information of the cardiovascular system, whereas actually it's a primarily endocrine question. Another investigation that I would like to do in this patient is complete blood counts with an auto analyzer telling me that the mean cell volume of this person is increased. Hypothyroidism is well documented to contribute to macrocytic anemia. The various causes of macrocytic anemia can range between vitamin B12 deficiency to folic acid deficiency, the traditional ones. Then can be chronic liver disease, then is aplastic anemia, and then is the topic of interest at the moment, that is hypothyroidism. Any of these causes that I have enumerated before you can contribute to macrocytic anemia, but hypothyroidism is because it's forgotten by us, and that is why he loves to ask that in the exam. Coming to the treatment of these patients, the standard treatment is levothyroxine. This has to be given on lifelong basis in both primary as well as secondary hypothyroidism. The dose of starting, not important for exam, is about 1.5 to 1.6 micrograms per kilogram of body weight. You have to be careful when you are giving tablet strength of more than 100 micrograms. Levothyroxine, which comes with the brand names like Eltroxin, is one name that you would have read. Another one would be Thyronorm. That's just for your information sake. It is available as 25 microgram tablets, 50 microgram, 88 microgram, and 100 microgram tablets. If you are prescribing more than 100, there could even be possibility of angina in a person. So, I mean, normally thyroid patient, hypothyroidism patient can be treated by almost everybody. MBBS doctor can treat easily a hypothyroidism patient. You don't need special training for that. But if the dose required of levothyroxine is more than 100, it is advisable that you send him over to a specialist or to a DM endocrinology, primarily because of the fact that I said as this hormone is given in large amounts, it can contribute to increase in oxygen consumption of the heart, and it can trigger even an angina. A lot of these patients are anyway having that increased cholesterol, no? So you would be stuck. Is it medicine that is contributing to angina, or is it the atherosclerosis component that is responsible? So that is why I said tablet strength more than 100 micrograms. Don't mess around, refer the patient. This medication is to be taken by the patient on a lifelong basis. Now I will give you a case presentation here. I'm describing a 60-year-old patient. This lady, she's a widower. Her husband had expired, let me say, due to COVID-19. Unfortunately, like, her husband was a diabetic and she's a hypothyroidism patient, and she has lost her husband recently due to COVID-19 pneumonia. She is a non-compliant patient of hypothyroidism. She's a widower, she lives alone, and her children are staying in America. Like, she has two sons, both of them are settled in America, and she lives alone in India. This lady, when she came to you this time for follow-up, she was suffering from UTI. Postmenopausal lady, UTI can definitely be there. Estrogen deficiency will decrease the defense mechanisms. So UTI is common in postmenopausal women. So you had prescribed antibiotics for this lady also for her urinary tract infection, but you are not very confident that she will take these antibiotics regularly. So you did remind her that, ma'am, you don't take hypothyroidism tablet, that is levothyroxine, regular basis, so please be compliant. After that, the patient went away, and the remaining history will be then retrospectively told by the relatives of this lady, or maybe her son who is calling you from America, or maybe the neighbors. This lady, she had come to your clinic in the evening. You sent her back with antibiotics, with the culture to be done on the same day or the next day, and well, she did not come out of her apartment for 2 consecutive days. Her son was calling her from America. She was not picking up the phone, so her son called up the neighbors, and the neighbors knocked on the door. She was not opening the door, so they called the security, went inside, and they went inside and they found that, this is after 2 days. She came to you today. After 2 days, this lady has been found unresponsive, unconscious in her bedroom. So, well, the neighbors brought her to your nursing home, like your clinic or your hospital is nearby, and she's under your care. You are working as a general physician. So she was brought in an unresponsive state to your clinic. This is after, let me say, 2 or 3 days of the visit. She visited to you 2-3 days back, and now later she has been brought in an unresponsive state. When you examined her, you found that her heart rate was relatively slow, that is about 60 per minute. BP was recordable about 100 by 60, let me say. So at least there is no need for immediate CPR in this patient, because at least the vitals are under your control. But you found that her body temperature was substantially reduced. When you used a digital thermometer or you used a special thermometer, you found that the body temperature was substantially low and she was icy cold to touch. So her son is asking you on a WhatsApp call from America, sir, why is my mom unconscious, unresponsive, and she's a known case of hypothyroidism. He himself knows that she does not take medicine regularly. You will explain to the son of this old lady that she had an infection recently, and infections in endocrine patients can be a disaster. Infections in endocrine patients can trigger endocrine emergencies, and the endocrine emergency that has been triggered in this case is called as myxedema coma. Please appreciate the fact that the main reason for myxedema coma is not non-compliance with anti-thyroid medication. If the question says what is the main trigger behind development of myxedema coma, the main trigger behind development of myxedema coma is any intercurrent illness. Here I gave a scenario of a UTI. It could be MI, it could be stroke or cerebrovascular accident, it could be pneumonia, it could be congestive heart failure, even excessive use of sedatives. You see, excessive abuse of sedatives can even trigger this endocrine emergency. So the bottom line is, like in diabetic patients, you could be having diabetic ketoacidosis or hyperosmolar coma being triggered. Similarly, here in hypothyroidism patients, intercurrent illness like UTI or the ones that I mentioned can trigger myxedema coma. And the coma, I mean, why the patient is comatose is explained by the decrease of body temperature. You see, body temperature decreases to this critically low value, the person will be unresponsive at this point of time. So, well, what am I going to do in this lady? I'm going to check her core temperature. I can run a ECG. In the ECG, because the heart is slow, the PR interval will be increased, the RR interval will be increased because there's a bradycardia component, and you might even get one of the ECG findings of hypothermia that has been discussed in the cardiology section, that is J waves. Even in the question, if J waves are not present, at least the bradycardia findings would be given in the patient. So I need to rewarm the body of this patient. Like in thyroid storm, when I started the discussion, I was discussing thyroid storm, I was using ice packs. This time I'm gonna use a space blanket to warm the body of this patient. The body temperature of this patient, let me say, is 34 decreasing to 33. So I need to do something to prevent heat loss from the body. Along with this, I need to give medicines to this person. So the main drug of choice for this person would be given as levothyroxine. We can be giving it with the help of a nasogastric tube to the patient. To test your pharmacology, though the next step that I'm saying is rarely used or because it's expensive also, we are also having T3 derivative available intravenously, that is liothyronine. So if he wants to test your pharmacological domain, that he wants to see whether you are familiar about the fact that T3 is also available in the market. You see, after all, T4 is converted into T3, no? So because of the intercurrent illness, the conversion of T4 into T3 might become defective. Lots of time, the person is very sick, the conversion of T4 into T3, the enzymes involved do not function properly. So you can provide T3 supplementation to the patient directly, and T3 is the active form of the hormone. So that will definitely help in improving the condition of this patient. Most of the time, the treatment of these patients is possible with conservative approach, and levothyroxine can be given by NG tube, and because the patient is comatose at the moment. But if required, levothyronine can be used along with the space blanket. Now, I just want you to remember the fact that in all endocrine emergencies, it is always a good idea to use steroids in the form of hydrocortisone. One reason why you are using hydrocortisone here is because it will increase cortisol, and cortisol, as I've explained, is the stress hormone in the body. So in majority of endocrine emergencies, you will definitely find regarding the usage of hydrocortisone. At this juncture, I would also like to say a few words regarding sick euthyroid syndrome. You see, any intercurrent illness can contribute to inhibition or conversion of T4 into T3. The main produce of the gland is T4. There is an enzyme by the name of D1 deiodinase. This was itself a question in physiology. T4 converted into T3 by which enzyme? The answer is D1 deiodinase. What happens in sick euthyroid syndrome is, due to the sickness, there is an impaired conversion of T4 into T3. So T4 is there, but it is not getting converted. So the active form of the gland is not being formed in substantial amounts. In sick euthyroid syndrome, initially the TSH values might be very, very less. In the recovery phase, the TSH values will come back to normal or might even be increased. Please remember the fact that TSH cannot be used to monitor sick euthyroid syndrome. It is usually seen due to severe intercurrent illnesses, for example, sepsis. There are two aspects that I've highlighted from hypothyroidism perspective with respect to illness. One, I have said, illnesses like MI, stroke, pneumonia, heart failure, they can trigger a development of myxedema coma where there would be a severe hypothermia in a person. But in some patients, the production of T4 will remain normal. See, the main point and difference between myxedema coma and sick euthyroid syndrome is, in myxedema coma, everything would be less. T4 will also be less, T3 will also be less. Here, T4 production is normal, but it is T3 which is reduced in the patient. So the main concept behind sick euthyroid syndrome? I mean, how do you differentiate from a patient of myxedema coma would be? In myxedema coma, both T4 and T3 are less. Here, it is T4 that is normal. It is T3 that would be substantially reduced. There are multiple cytokines involved here. One of the one incriminated here is interleukin 6, the same one that is involved in cytokine storm or like we read about COVID patients deteriorating in the second week. That's again because of interleukin 6 values, and we are forced to use drugs like tocilizumab for the patients. In this discussion, I have also used the term accelerated atherosclerosis. So it gives me an opportunity to make you remember where in the entire app have I used this term repeatedly. Let's just summarize it. Accelerated atherosclerosis has been discussed for autoimmune disorders and rheumatology for SLE and rheumatoid arthritis, diabetes mellitus patients, and chronic renal failure, which is currently framed as CKD. And diabetes causes CKD is also having accelerated atherosclerosis. Even hemodialysis increases cardiovascular mortality by causing accelerated atherosclerosis. In cardiology section, I have talked about syndrome X. Syndrome X would be an individual having metabolic syndrome. Then would be nephrotic syndrome. Yes, even nephrotic syndrome is where I have spoken regarding accelerated atherosclerosis. These disorders are anyway to be remembered by you, and do not in the exam confuse sick euthyroid syndrome with respect to myxedema coma. And if in doubt, then myxedema coma incidence wise is relatively more common. So these are the details that I would like you to remember for this topic. Do try to break up your task into smaller topics every day. Don't try to make a big task like I'll do the entire thyroid disease in one day from medicine as well as from surgery as well as from pathology. It won't be possible. Make up subtopics, make up micro topics, and try to cover them on a regular basis. As I highlight every time, knowledge is power. You need to continue building that up, and as you will grow, as you will learn more knowledge, you will be feeling more confident in your approach to multiple choice questions. Thank you so much for hearing me out.